And if you look at the numbers of bypasses needed for these, it's nearly half of these. I've come to the conclusion, the more I do these, that these are best treated with a different kind of a strategy than clipping, that these are best treated with a bypass strategy. And so I'm going to talk to you a little bit about my thoughts on the bypass generally, and we'll look at some giant aneurysms in particular. What do I see in the future? Well, I think a lot of giant aneurysms will be treated with flow diverters and collaboration with our colleagues, whether they be other neurosurgeons or neuroradiologists or neurologists. I think that the bypass complexity is going to be going up. We'll be seeing more complex fourth generation style bypasses, and I'll explain what I mean by that. We'll also, I think, see novel applications of bypasses. And I'll finish just on some comments about nomenclature and paradoxical volume. So the first point I want to talk about is just bypass complexity. This is I'm going to show you two cases of intracranial bypass. You'll see here this code for the bypass. These alphanumerics are meant to describe exactly the bypass that you're going to see. And hopefully by the end of this lecture, you'll know what that code means. So this is going to be an intracranial to intracranial bypass that we'll start with. These are bypasses that use either reimplantation techniques, in situ bypasses, reanastomoses, or these short interpositional bypasses, or some combination thereof. This is the first case I wanted to show you. This is a woman from the Middle East in her late 20s. She initially presented in January of 2020 with this aneurysm. And you can see over a year and a half, it grew to a giant size at the basilar apex. This CT angiogram shows the anatomy. It's dolichoectatic with trunks coming off the underbelly here and off of the sidewall over here. You can see it's giant in size, and I'm going to just jump you straight to the video. For this, what I decided to do is a M2a2 bypass, meaning a bypass from the middle cerebral artery, which we can see here, to the posterior cerebral artery, which comes from the aneurysm, which we see here. And so this is our recipient artery here in the depths of the sylvian fissure, and our donor is up here in the more proximal sylvian fissure. So the bypass here gets stitched into the P2 segment. The aneurysm is over here, and this is an end to side anastomosis. And so you can see how nicely the radial artery serves as this interpositional jump graft for us. And here's the back wall going in. And we can very nicely complete that very deep anastomosis down to the PCA. Now our clips come off and we've shut down the bypass graft, and we can turn our attention higher up in the sylvian fissure. This is the M2 over here. And we're sewing in our proximal end of the radial artery graft. So this is our donor vessel here. And so this is what I mean when I say an M2a2 bypass. This is the M2 segment of the middle cerebral artery, and we're going to sew this in. So I like to use a running continuous suture technique. You can see the running continuous suture technique allows you to just expedite and speed up the sewing. This is the back wall going in here. And now what you see is the bypass here is, it's looking good. And we see good bounding pulse in the bypass. And now we turn our attention down here to the basilar trunk. So this is now the window over the dorsum, and we get down to the point where we put that proximal occluding clip on the basilar trunk. Now you see a problem here with the graft. We see that the graft is no longer filling, or not filling properly, so we've got to do some troubleshooting. We've got to cut the graft out. We've got to clean out the proximal end, and we've got to redo this. This is now an end-to-end reanastomosis here. So what we've essentially created is a double interposition graft. We've got the first attempt at our graft down below. We've got a second attempt here above, and this is on the recipient end. And now with that in place, we can come off with the clips. And everything looks good here. And now going to the middle cerebral territory up here, this is now the donor site. And we're going to redo this, the donor site to a different M2 branch. So this now is the redoing of the donor site here. Again, an end-to-side anastomosis. This is a nice view of the intraluminal suture line. We flip the graft here and we continue onward. And now our clips come off, and now we have a fully functioning bypass graft. So here you can see a healthy graft. You can also see down in the depths there a good bypass. We put our clip back on the basilar trunk, and now you can see this reversal of flow in here. This is flow through the aneurysm from right side across the aneurysm to left side, and that really was the whole intent, was to reverse the flow in the aneurysm and eliminate the inflow. This is now that double interposition segment of the graft. You can see our bounding artery here, and our basilar aneurysm is much softer. We've reversed the flow, and this is just our final overview showing this nice bypass here from M2 right here down to P2. So that was the double interposition bypass from M2 to P2 with flow reversal in the aneurysm. And you can see that with that bypass, the flow here changes directions, and you see stasis and elimination of flow. And that eventually led to this aneurysm shutting down nicely. Now, here's our next case. This is another giant aneurysm. You can see it's largely thrombus filled. This is the spin here. And what we're going to do for this is an M2 radial artery graft to the A2 segment. So it's an M2a2. But we're also going to do an A3 bypass. And the idea here is we take this normal anatomy with A1 flowing in and ACOM communicating left to right, and then this outflow finding its way. We're going to recreate the elements of that bypass with this interposition graft, with this A3 bypass over the top, and then just allowing the flow to find its course. So here now is the view. This is what I call a squeeze play, which means we have two exposures and one craniotomy. This is the view down the interhemispheric fissure, which we see here. This is now the view of the A3 segments. And you'll see here these A3 vessels come together very nicely right down the interhemispheric fissure. So we're going to bring those together here with a side-to-side anastomosis. This is the inner layer of artery coming together. I'm just going to jump ahead here a little bit and show you the bypass at the end. This now is the attention turned to the subfrontal region. This is the A1 coming in. This is the recurrent artery of Hübner in between. And this is our A2. So what we're going to do to supply the inflow to the system is we're going to do this M2a2 bypass. So this is the A2 segment here. We've made our arteriotomy, and we're going to stitch our graft into the A2 segment here. And this is an end-to-side anastomosis. So we'll just expedite the suturing here. This just completes that anastomosis down at the A2. Now we go to the Sylvian fissure. This is the M2 coming off the M2 trunk, and this will be our donor site. You can see that I'm showing this anastomosis from inside the artery. This makes this an intraluminal suture technique, and this will become important later in our discussion of fourth generation bypass. But I'm showing this artery from the inside, and that is allowing me to shorten the graft. You can see now this is at the halfway point. I've shown the deep wall. We now transition from intraluminal to extraluminal here with this stitch, and then we continue on. So now we've got this stitched up here, and our inner position graft is now completed. So we come off with our clips, we see good flow, and now we can turn our attention now to the aneurysm. This is now inflow down here. We're going to close that off with our aneurysm clip. You'll see recurrent artery of Huebner right in the middle here. We're going to close off the A2 just after the ACOM on the outflow side of the aneurysm with this curved clip. And now the aneurysm is shut down, and when we do our flow study, we see that there is flow in the recurrent artery of Huebner. That tells us the flow is going from our bypass graft up the A2, across from the A3 bypass, and then down. So we've created this whole new circuit for flow, which you can see here. We've got our purple inflow vessel. We've got our A3 bypass up here at the blue arrow. And you've got flow that goes all the way down retrograde, and the aneurysm itself no longer fills. So again, giant aneurysms are a totally different animal. They require a different strategy than just clipping. They really do rely on bypass. Now, what those cases showed you is this idea of the fourth generation bypass. And what I mean by that is that whenever we use a conventional construct, like what you see in this diagram here, but we use an unconventional sewing technique like the in situ technique, then that's what I call a type 4A bypass. The type 4B bypass is an unconventional construct, and I'm going to show you examples of what that looks like. This is a table, our 7 bypass table, and you can see that when you break out the table but add these fourth generation constructs, we get many more options that are available here. You get options that are available that are not only third generation, as we see here, but also other ways to do reimplantation or reanastomosis or these interpositional bypasses. And these are what some of those will look like. These are different ways to reimplant. These are different ways. Well, this is a case example. This is a double barrel STA-MCA bypass. This is an example of what I call the middle communicating artery. And you'll see from this animation that we'll just do a standard double barrel bypass, but we're going to do a reimplantation of these trunks end to end to one another. So that here's the bypass going in, but now watch what happens to these trunks. We can take them off of the aneurysm. We can sew them together end to end, or in other words, do an end-to-end reimplantation. And when we do that, we create what I call this middle communicating artery. And so this is an example of that. This is the aneurysm in the Sylvian fissure. We do our double barrel STA-MCA bypass, which you can see here. And once that's in place, we can then trap this aneurysm. We can cut the trunks of the middle cerebral vessels off of the aneurysm. And now you see the stumps. They're going to be sewn together to one another. This is an end-to-end reimplantation. So each of these two trunks connects with one another. That's an intraluminal suture line. Here now is the extraluminal part. And we're building a communicating artery. Just like the ACOM or the PCOM, this is a middle com because it communicates the middle cerebral arteries together.
You have 5 minutes, please.
I'm sorry, what?
The time you have 5 minutes.
Okay, great, thank you. So here's the post-op view showing that reconstruction here with the middle communicating vessel created. And we can do that in a variety of other ways. This is a picket fence clip reconstruction of this giant aneurysm. You can see a good result here, but at 5-year follow-up, the aneurysm recurred. So for this case, what we'll do here is, again, create another middle communicating artery. We'll sew in a radial artery graft into one trunk, and then we'll cut the trunks off of the aneurysm, and we'll bring them over, and this creates our middle communicating artery in here. So this is yet another example of this, what I call the MCOM. And in the interest of time, I'm just going to take you down to the sewing here. This is sewing the radial artery graft into the M2 trunk, which you can see here. And now what we're going to do, we're going to take this trunk off of the aneurysm, which is here. We're going to cut that free. And then this stump that would otherwise have been a dead end can then become a donor vessel, which we swing over to the other side here. This is the other M2 trunk. And we can join those two in this MCOM. So here's the inner layer of the suture line being brought together. This is the outer layer, and now we've created this middle communicating structure. So last points, there are many ways to treat these dolichoectatic vessels that are compressive of the brainstem. This is a sling technique that uses an aneurysm clip in the clival dura to tack the artery away. But here's an example of a bypass option. This is not really a giant aneurysm, but you can see a vessel that's compressive on the artery. And we have what we call a binder ring bypass, which in this example here, you can see the vessel elongates, it compresses the 7th and 8th nerve complex. And here what we're going to do, we're going to transect the artery. We're going to bring it around the outside of the nerves, and then we're going to sew the artery back together again. And this is an application of bypass technique to treat dolichoectasia on the basilar trunk. And here you see how that reroutes the vessels outside the nerve roots and allows them to be off of the nerve. So this is what that case looks like in real life. I'll just quickly show you the rerouting. This is after transecting. This is now bringing the arteries on the other side of the nerve. So you can see the rerouting of this artery to the outside of the 7th and 8th nerve bundle. And our bypass technique is to just bring these vessels back together again. You can see this thick tissue here. We're sewing intraluminally on the inside. And here coming around the outside, this completes our repair. And what this does, it just brings the offending pathology to the outside of the nerves so that they're no longer under compression. And this addresses this patient's symptomatology. So this is yet another application of bypass. As you can see nicely here, the vessels are now rerouted outside the nerve. So I'll finish up by just talking about nomenclature. These are various symbols that we invented for describing our bypasses and making these blueprints for the bypasses that we construct. You can design different bypasses using what we call the Barrow bypass coder. You can click on these icons, drag them over to the image here, and you can practice or build your bypass. And this nomenclature that we put together here with Dr. Rotan allows you to then take a bypass and code it. You can put all of the detailed information into this string of alphanumerics so that when you get a complex case like this and you want to build a complex bypass that looks like this, you can have a code that tells you exactly what you're creating. And this, I think, can be applied to any bypass that you can dream up. These are the MCOMs, or the middle communicating arteries here. This is the schematics, and these are the codes that go with each one of those. So just to conclude, aneurysm volume is declining from an open perspective worldwide because of the endovascular increases. But in contrast, bypass numbers are continuing to go up. And I think it's one bright spot in the open surgical field where we can see how the bypass is an important part of our our practice. So just to conclude, I think to do these cases, it takes a good microscope, it takes developing your skills, seeing a lot of anatomy and pathology, repeating these cases over and over again, going over your results, and then finally just working hard at this. And eventually we can get to the point where these bypass options become available for these tough aneurysms, like the giant aneurysms. So with that, I will stop, and I thank you very much for inviting me.
Thank you very much, Michael, for taking the time. I know it's late in Arizona. Are you connected yet, Ahmed? I don't think he is, unfortunately. Let me just show you, Michael, the auditorium there.
Oh, yeah.
Okay.
Thank you, Professor Mikhail, for your presentation. And my question about what is about vasospasm post-operative in these cases, please?
Sorry, what was the question?
Can you repeat that, please?
What is about post-operative vasospasm in these cases? If
Yeah, so vasospasm in a bypass case is really no different than vasospasm in a clipping case. The risk is there. If it's a subarachnoid hemorrhage case, there's the possibility that there could be some vasospasm to manage in the week or 2 weeks afterwards. But we still continue to press patients if necessary, and the bypasses are good and strong for that.
Thank you. And what is about epilepsy in these cases?
What about which?
The patient needs anti-epileptic drugs, and for what type? The duration of the treatment.
Could you repeat it again, please, clearly and slowly?
What is about the post-operative epilepsy?
Oh, epilepsy, sorry. Yeah, so we don't use I don't use anti-seizure medication unless the patient has presented with a seizure already. If they've just come in with a ruptured aneurysm, or if this is an unruptured aneurysm, then I don't normally treat with anticonvulsants, no.
Okay, thank you, Professor. We see if there is any question from our college here.
Second lecture with Dr. Tariq Twice. What the eye can tell you about the brain. Proceed, Dr. Tariq.
Thank you, Professor Mikhail. Thank you.
Thank you.
Okay, thank you, Michael. We won't keep you too long. Okay, do we have the speaker for the next spot? Are you guys connected yet?
The second speaker is Dr. Tariq from here, from Yemen, about what the eye can tell you about the brain.
Okay.
He will start now.
I am Dr. Tariq Twice, ophthalmic consultant. I will tell you today about what the eye can tell you about your brain. نعرف إنه ال eye is the window of the brain. Most disease can be discovered by eye examination. بالتالي our vision depends not just our eye examination, but on the full visual pathway from eye to brain. Injury to this visual pathway at any point lead to vision loss. First, we can speak about the fundus. الفندس معنا الاوبتيك نيرف، ماكولا، ريتينال بلاد فيزلز، باك جراوند ريتينال ثورويد. اللي يهمنا احنا في النيوروسيرجري هي الاوبتيك نيرف. You must be any neurosurgeon doctor examine our optic nerve by himself. normal optic disc الcolor بيكون slightly reddish to yellow. small white depression in the center نسميها optic cup. يكون round or oval. margin يكون sharp and well defined. How to examine optic nerve by direct ophthalmoscope. Indirect ophthalmoscope. Indirect slit lamp biomicroscope. fundus camera. يكون بهذا الشكل round or oval slightly reddish و well defined. بنتكلم عن 4 أشياء أساسية. أول شيء الأوبتيك نيرف. third cranial nerve. fourth cranial nerve. and last one sixth cranial nerve. الأوبتيك نيرف أهم ديزيز في الأوبتيك نيرف يهمنا نيوروسيرجري هي البابيلوإديما. As a definition is the swelling of the optic disc nearly always, sometimes asymmetrical, bilateral, sometimes يكون asymmetrical. Causes of papilloedema إما primary causes like idiopathic tumor cerebri أو secondary cause like hydrocephalus, shunt failure, mass lesion like tumors, hemorrhage, large infarction or abscess, meningitis, encephalitis, subarachnoid hemorrhage, trauma, arteriovenous malformation, intracranial or
سلولي
extracranial.
دكتور طارق سلولي شو
10 نقط بس. Okay. Trauma, arteriovenous malformation with high blood flow, intracranial or extracranial venous obstructions, or secondary due to tumor cerebri syndrome due to certain systemic disease, drugs, or pregnancy. كيف نشوف البابيلوإديما؟ مثل ما قلنا أول شيء bilateral but might be asymmetrical. Usually present visual acuity. هنا يجي لك المريض الفيجوال اكوتي تبعه 6 لكن يكون عنده حاجه اسمها color vision loss. يبدا الكلر فيجن يضعف عنده. يكون عندهم حاجه اسمها transient visual loss lasting second. يشتكي المريض انه وقت من الاوقات فيجن لوس يستمر كم ثواني. ايضا يكون عندهم حاجه اسمها visual field defect. جزء من الفيلد تبع المريض يحدث له ديفكت. اخر شيء اللارج بلايند سبوت. يشتكي المريض انه في نقطه سوداء امام عينه. هذا الشكل البابيلوإديما. مثل ما قلنا الاوبتيك نيرف المفروض يكون ويل ديفاين شارب اد. هنا ما نحصل انه ما فيش اي اد للبيوبل عفوا للاوبتيك نيرف. في الايرلي بارت يكون الكلر مينيمال ديسك هيبريميك due to capillary dilatations. المارجنز يكون بلير وغالبا يكون في نزلي or superiorly inferiorly جزء معين من الاوبتيك نيرف. might be slight elevated. الفيزل تكون نورمال والريتينال اديماتس around the disc. لكن في المراحل المتاخره الديفلوب بابيلوإديما الكلر يكون جريرد. السايز increase diameters. المارجن بليرد elevated. الفيزلز elevated. الارتريز والفينز تورتياس والريتينا around the optic nerve تكون اديماتس بهذا الشكل. الديفاين اد increase diameters hemorrhage edema around optic nerve. Second disease of the optic nerve is optic atrophy. Optic atrophy as a definition is shrinking from any process that produce degeneration of axons in the visual system. Classification of optic atrophy primary or secondary. Secondary post babylloedemic optic atrophy, post neurotic optic atrophy, or glaucomatous or consecutive optic nerve atrophy. البريمري يكون وايتش بهذا الشكل ويكون well defined edge. السكندري يكون ill defined edge وإديماتس around the optic disc. Like this. edema around optic disc والoptic disc margin not clear. فوستر كينيدي سيندروم هذه بتعمل لنا تيومر in the anterior cerebral fossa. في المكان اللي فيه التيومرز يكون شكل الاوبتيك نيرف اتروفي. في الكونترالاترال اي بيكون شكل الاوبتيك نيرف بابيلويديميك due to increased intracranial pressure. بيكون عين بهذا الشكل بابيلويديما وعين اوبتيك اتروفي. اوبتيك نيورايتس ريتروبالبر اوبتيك نيورايتس في الغالب يكون no symptoms no signs no signs. patient complain decrease or change in vision. ايضا الريد كلر بتاعه بيختفي. يكون بابيلايتس هايبريميك ايديما نيوروريتينايتس بابيلايتس with retinal nerve layer inflammation and macular oxidation بهذا الشكل. نفرق بين البابيلوإديما انه يكون unilateral decrease color saturation الفيجوال فيلد افكشن وبين during ocular motility. Second nerve of the eye can cause disease that related to brain. Third cranial nerve عبارة عن nerve innervated the superior, inferior, medial recti and inferior oblique muscles. It's also an innervate levator valvular superiosis and carried with the parasympathetic innervation to the pupil. يجي لك المريض عنده توسس، عنده اكزوتروبيا، limitation في الادكشنز، limitation في الاليفيشنز وليميتيشن في الدبريشن. ينقسم الثيرد كرينال نيرف الى نيوكليار فاسيكولاس بازيلار انتراكافيرناس انترا اوربيتال وبابيلو موتور فايبرز. في النيوكليار situated in the midbrain at the level of superior colliculus most frequently cause palsy or vascular disease, primary tumors and metastasis. Involvement of barred medial rectus subnuclei cause well eye bilateral intranuclear ophthalmoplegia characterized by exotropia and defect convergence and adductions. Fasciculus, the afferent fiber which pass from third nucleus to red nucleus and medial aspect of the cerebral peduncles. Cause of nuclear and fascicular lesion are similar except that demyelination دائما تصيب fascicular part of third cranial nerve palsy. Basal part start as a series of processes left midbrain in the middle aspect of the cerebral peduncles. يهمني انه اذا كان isolated third nerve palsy في الغالب هذا basilar part of cranial nerve palsy. اللي يهمنا في البازيلار بارت انه اذا في انيوريزم في البوستيريور كوميونيكيتنج ارتري the junction between internal carotid artery typical present acute painful third nerve palsy. Head trauma resulting extradural subdural hematoma cause tentorial pressure fall with downward herniation of the temporal lobe and compressed third nerve and passes over the tentorial edge. تعمل لنا في البدايه مايوسيس بعدين بترجع الوضع الطبيعي للثيرد نيرف اللي هو الميدرياسيس. ايضا intracavernous part of third nerve enter the cavernous sinus by burst the dura lateral to the posterior phrenoid process. الcavernous sinus ينقسم الى superior and inferior branch sometimes affected one branch ويجي لك defect في one muscles only. اهم اسباب للintracavernous third nerve palsy هي diabetic pituitary apoplexy اذا حدث لها hemorrhagic infractions intracavernous pathology such as aneurysm meningioma, carotid cavernous fistula, granulomatous inflammation like Tarusa-Hunt syndrome. Third nerve that affected the eye and related to brain, fourth cranial nerve. The fourth cranial nerve is the only cranial nerve emerged from the dorsal aspect of the brain. هو cross nerve وبالتالي الnucleus of the right innervated left eye والnucleus of the left innervated right eye. هو very long and cylinder nerve. البيشنت هنا بيشتكي من ديبلوبيا وخاصة أثناء القريب أثناء الريدنج أو بيتحصل لما ينزل من الدرج بيشتكي من هذا الشيء ويكون عندهم هيد بوستشرز يعمل هيد تيل بحيث إنه تو أبليش ديبلوبيا أو يخفف من الديبلوبيا الحاصلة عنده. يجي لك بهذا الشكل داخل في العيادة وعنده ليميتيشنز في الداونورد انورد وهيد تيل. نفس الفكرة composition of fourth nerve من النيوكليوس fasciculus trunk intracavernous intraorbital. And nucleus located the lever of the inferior folliculus ventral to Sylvian aqueduct, caudal and continuous to the cranial nerve 3. And fasciculus curve around the aqueduct, decussated completely in the anterior medullary venium. A trunk leaves the brainstem to the dorsal surface, caudal to the inferior folliculus, and then curve laterally around the brainstem, round forward beneath the free edge of tentorium. Like third nerve, pass between the posterior cerebral artery and superior cerebral artery, then burst dural and enter the cavernous sinus. السكس نيرف disease أو sixth nerve palsy يغذي لنا lateral rectus muscle. هنا البيشنت يشتكي من limitation in abduction و sometimes head tilt to decrease diplopia. الدايجنوسيس انه ايزوتروبيا عينه للداخل، limitation في الابدكشنز وهيد تيلت. النيوكليس دائما في البونز وليزن around the sixth nerve nucleus caused following signs: ipsilateral weakness في الابدكشنز as a result of involvement of sixth nerve. الفاسيكولاس passes ventral leave the brainstem and pontomedullary junction. السيمبتومز ممكن يجي لنا حاجه اسمها foveal syndrome caused by vascular disease, tumor involved the dorsal bone, characterized by ipsilateral involvement of sixth nerve, seventh nerve, central sympathetic fibers, and trigeminal nerve. Bilateral facial analgesia, sixth nerve palsy with gaze palsy, and facial weakness, deafness, and central hornal syndrome. أيضا Miller Gubler syndrome involve fasciculus as pass through the pyramidal tract and most frequently caused by vascular disease, tumor demyelinations. المريض بيشتكي من sixth nerve palsy, contralateral hemiplegia, variable number and signs of dorsal pontine lesions. Basilar part leave the brainstem pontomedullary junction, pass upward through to the base of the skull, burst dura below the posterior crinoid and angles forward over the tip of vitreous bones, pass through and around the inferior petrosal sinus, through dorsocranial to internal cavernous sinus. Important cause of damage to the basilar part: acoustic neuroma, damage to sixth nerve in the pontomedullary junction. First symptom is hearing loss. The first sign is diminished cornea sensitivity. Always test for hearing and cornea sensitivity on all patients with sixth nerve palsy. Number 2, nasopharyngeal tumors involve the skull and is foramina endemic to the nerve during basal course. Raised intracranial pressure caused by posterior fossa tumors. Idiopathic intracranial hypertension caused downward displacement of the brainstem, stretching sixth nerve and the petrosal lip. Basal skull fractures أيضا بيعمل لنا sixth nerve palsy. Girdingo syndrome caused by acute petrotitis. Is combined by facial weakness, pain, and hearing difficulties. Intracavernous بيمشي around the third and fourth nerve.
دكتور طارق time is off already. Time is on.
Conclusion: the ability to see the result of intracranial system of the communication between the eye and optic nerve and brain. Problem affecting the nerve in and around the eye can result in several different conditions. Prominent accurate diagnosis is important for preserving vision and address symptoms. Thank you.
Thank you very much for this very nice presentation, Dr. Tariq. Any question for Dr. Tariq?
Dr. Tariq, my question about the sparing of the third nerve. You thought we can differentiate between that if it is diabetic, it will spare the third nerve, the pupil. It is a pathognomonic or, I mean, if there is a sparing of the third nerve, should we look for something else in the brain, like aneurysm, compression, subarachnoid hematoma, or?
The dilatation pupil في third nerve palsy is not clinical for 100%. Almost. بالتالي أي مريض عنده dilatation ممكن نقول إنها pathognomonic for clinical. لو المريض third nerve palsy والبيوبل not dilatation عنده systemic disease like diabetic hypertension بنرجع السبب للسيستميك disease. لكن if not improvement 1 week 2 weeks ما في أي تحسن we must be refer patient for MRI.
Thank you.
يعني in many cases in neurosurgery we are sending patient to you to detect if there is papillary edema or not. For example, in NPH, normal pressure hydrocephalus, in many يعني conditions, other conditions. So according to your re-answering, we will decide to operate or not, to do LP or not. So what is the accuracy of papillary edema check-up, I mean fundoscopy? What is the false negative يعني?
في ال early stage of papillary edema you must be examined by expert ophthalmologist. لأنه ما تكون واضحة جدا وتكون يعني one part of optic nerve blur.
I mean in the hand of the expert ophthalmologist.
100%.
Okay.
But you must be in your surgery examine optic nerve. نعمل لكم course.
Should be يعني.
نعمل لكم course how to examine optic nerve.
Yes, every neurologist should be with the.
That's it.
Thank you very much.
Okay. Time off, they told me. Okay.
So we will come to the next lecture by Ustad Dr. Yahya Sayaghi or Ustad Dr. Bashir Uthman about tendon transfer after radial nerve injury, benefits and outcome, advantages and outcome.
Assalamu alaikum. I'm Dr. Bashir Uthman, consultant of plastic and reconstructive surgery. Thank you very much for your invitation for this conference. We are going to present the role and advantages of tendon transfer after acute and chronic nerve injury with my senior prof, Dr. Yahya Sayaghi. We are talking in radial nerve injury. We are, as we know, we are facing in this situation a lot of trauma to the radial nerve, and the radial nerve injury causes major disability for the patient. As we know, it is the drop hand. Okay. The radial nerve is the most frequently injured major nerve of the upper extremity. Splinting to maintain joint motion and function. As we know, الراديال nerve هو most common injury. Okay. The radial nerve is the most frequently injured major nerve of the upper extremities, اللي هو الراديال nerve من الميديان والulnar, as you know, the three main nerve to the upper extremity, and it causes hand drop or wrist drop. So splinting is very important. Splinting is very important point in maintaining the function, because if there is maintaining a wrist drop like this, there will be a lot of problems. اول حاجه هيكون في جوينت، ممكن جوينت ستيفنس، وممكن يحصل تندينوزيس، لوز اوف تندينوزيس افكت على الفليكسر تندون. فالسبلنتنج is very important. Here we will discuss the role of tendon transfer in the acute stage as a splinting solution, and the tendon transfer later on as a definitive treatment. A prospective study of 30 cases of radial nerve injury underwent tendon transfer as early splinting treatment in conjunction with other treatment modalities. هنجي نتكلم عنها or as late definitive treatment. Tendon transfer provide alternative effective treatment for radial nerve injury in the acute stage or chronic stage. Okay, we'll start with the anatomy. As you know, الاناتومي of radial nerve، كلنا نعرف الاناتومي of the radial nerve ان هو عباره عن terminal branch of the posterior cord. It travel in the posterior compartment of the arm, in the anterior compartment, and in the posterior compartment of the forearm, two branches. two branches اللي هي superficial sensory والdeep motor اللي يسموها posterior interosseous nerve. It gives at multiple level branches to muscle. In the arm, mainly the mainly muscle supplied by the radial nerve is the triceps muscle اللي هي the major extensor of the elbow. In the forearm, it gives supply to all the extensor muscle of the wrist and fingers. Okay, what are the causes of radial nerve palsy? As we know, direct trauma is the most common cause, especially in our situation when we see a lot of open fracture, a lot of open wounds, even in civilian communities or society. We see it stab wound or a motor car accident. Then the trauma is the most common cause of radial palsy, commonly associated with humerus fracture, either open or closed fracture. Other etiological factors may cause the loss of radial nerve function, for example, systemic disease such as diabetic, arthritis nodosa, alcoholism, serum sickness, or the loss of function may result from general neurological disorder. Dysfunction may also result from internal anatomical compression associated with spontaneous compression syndrome or the presence of tumor. Okay, what are the deformities and loss of function in radial nerve palsy or radial nerve injury? As we know, drop hand or drop wrist, which is inability to extend the wrist, loss of finger extension at the metacarpophalangeal joint, inability to extend and abduct the thumb. This is commonly referred to as the wrist drop deformity. Even here we see the main problem is in the extensor muscle of the hand. عشان كده بيطلع a drop hand or a drop wrist. But in radial nerve injury, this is the classical drop hand. As we see, major disability for the patient. In radial nerve, not only the problem in the extensor, only the flexor is affected. How is affected? By this position, as we say, in the normal position, the fisting power is good. And the patient can fist normally when the wrist is extended. But during the palsy or drop, the fisting power is decreased. اي حد يمكن يعملها لانه الديكريز الباور بتقل جدا في الفليكسور. اوكي. فده بالتالي بيأثر على الفليكسور تندون. يحصل shortening. This is due to an overstretching of the extensor muscle and shortening of the flexor muscle. This is a radial nerve palsy. واضح انه مش قادر يعمل fisting.
Tendinosis effect, same meaning.
Yes, the tendinosis effect. This is the tendinosis effect in grasp releasing grip. Okay. The loss of the power in the wrist and finger extensor destroy the reciprocal tendinosis action. That is essential to the grasp release pattern of the normal hand function. Splinting to preserve movement and prevent overstretching of the denervated muscle is particularly important when the recovery is prolonged. يعني اذا حصل nerve injury سواء هنعمل له conservative او نعمل له nerve repair whatever, هنا السبلنتنج is very important to prevent an overstretching و to prevent the complication من shortening of the flexor muscle. اوكي نتكلم عن the modalities of treatment. We know سواء كانت whatever the cause of trauma, the management سواء كانت closed or open trauma that cause the radial nerve injury, the modality of treatment is either conservative, nerve repair, or tendon transfer. All these modalities of treatment require splinting. طيب conservative treatment كنا نعرفها طيب انه external splint, physiotherapy for 6 months up to 1 year. Then you can do exploration او تنتقل على طول للتندون transfer. Nerve repair either direct nerve repair, nerve graft, or nerve transfer. And this also need external splint, physiotherapy for 6 months to 1 year, and then إذا ما في أي recovery, if there is no recovery, we return to tendon transfer as the last option. But طبعا this is one of the external splint اللي يلبسها المريض طبعا بعد النيرف ريبير أو أثناء الكونزرفاتيف مانجمنت. Okay, what is the problem? What is the problem if we are going to do nerve repair and external splint? patient compliance to the long time of wearing such splint. الاكسترنال سبلنت متعب شويه للبيشنت وما في بيكونش عندنا بالذات في السوشيتي حقنا ما بيكونش عندهم good compliance to wearing the external splint. A long time of wearing the splint. The need of continuous physiotherapy to prevent joint stiffness and shortening of the flexor muscle. The expectant poor prognosis, and finally the need of tendon transfer, especially if there is a long segment of the nerve of loss. يعني كانش primary كان مثلا graft, nerve graft or nerve transfer. Usually the prognosis is not that good. So the last option is the tendon transfer. Tendon transfer, we are talking, يعني from the first about the splinting. In the tendon transfer, it will, we present the early tendon partial transfer as the time of trauma, as the time of nerve repair, is partial tendon transfer to act as internal splint. يعني نقدر نستغني على الاكسترنال splint. And the late complete tendon transfer اللي هي definitive treatment. Early partial tendon transfer act as a splinting solution. We transfer, we do incision in the anterolateral aspect of the upper forearm. Okay, we do transfer of the pronator teres, اللي supplied by median nerve, to the extensor carpi radialis brevis, اللي بتعمل rest extension. Okay, this is act as internal splint. صح we do بعد كده back slap, just back slap for 3 weeks، لكن بيستغني المريض بعدها عن الاكسترنال سبلينج اللي ممكن يقعد for 6 إلى 1 year. 6 إلى 1 year، especially احنا if we are doing nerve repair. If we doing nerve repair, we prefer انه نعمل early small tendon transfer and no functional deficit، ما بيعملش اي حاجه، البيشنت satisfied after the operation. يعني اقصد انه بعد ما يطلع او يكون طالع حتى من العمليه، حتى بعد النيرف ريبير ما بيطلعش على طول عامل الاكستنشن، لكن هذه بتعمل لك شويه تروما، some trauma to the patient after the operation. But if you do tendon transfer with the nerve repair as partial tendon transfer عشان تنتظر النيرف ريبير حقك كيف حيكون.
الناس دكتور بشير.
What?
The time.
Okay, early partial tendon transfer قلنا act as internal splint, reduce the time of wearing the external splint, no functional deficit, and the ability to return to complete tendon transfer if there is no recovery. ده اخر حاجه اللي complete tendon transfer، اكثر حاجه بنستخدمها البراند. هذه طبعا لما يكون ما فيش نيرف ريكفري خلاص ما حصلش وكده بنرجع للكومبليت تندون ترانسفير. وي دو كومبليت تندون ترانسفير اللي هو الثري تندون ترانسفير، في اكثر من حاجه اللي هو الجونز والبويس والبراند. وي ار يوزنج ذا براند اللي هو ريست اكستنشر pronated teres to extensor carpi radialis brevis, flexor carpi radialis to extensor digitorum communis, and palmaris longus to extensor vellocis longus. And we perform the transfer in sequence rest finger then thumb. تفضل بعد منكم. This is classical phase of wrist drop. هذه بعد after tendon transfer, early tendon transfer. We can extend the hand normally and by special splint فترة طويلة. هذا الفيديو.
الثاني بعد ما شلنا السبلنت بعد 3 أسابيع من التندون ترانسفير، يعني الاحظ ان المريض يقدر يفعل الشخص كامل فول اكستنشن والثم برضه يعني
الفيديو. ما شاء الله.
ايوه 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 ايوه
بس هي الفكره انه يعني التندون ترانسفير مش حيضر الفليكشن نهائيا. والشيء الثاني انه يساعد المريض انه يعمل فيزيوثيرابي. استخدام الهاند هو ذا بيست فيزيوثيرابي. شكرا جزيلا.
إذا دكتور as conclusion التندون ترانسفير سواء كانت early أو late is effective treatment for radial nerve injury. احنا بنأكد على early tendon transfer لأنه عندنا دايركت تروما كثير للراديال نيرف، وبالتالي المريض بيطلع بيجلس على فترة طويلة ان هاند دروب يحصل له مشاكل الجوينت ستيفنس وكذا. بنعمل له الايرلي تندون ترانسفير بيتر يعني in conjunction with the nerve repair مع النيوروسيرجن at the same time. Thank you very much.
هذا هو الكلام. يعني الفكره انه اذا عملت نيرف ريبير بياخذ وقت طويل على ما يتحسن.
Very good.
المريض بيكون غير راضي عن العمليه. واحد
yes.
السبلنت بيضطر يعملها،
بيضطر
الدينامكتايد
for long time.
بالضبط. والفيزيوثيرابي بيعتمد على الاخرين يعملوا له فيزيوثيرابي فتره طويله.
yes.
اذا عمل نيرف ريبير وتندون ترانسفير في نفس الوقت وفرت عليه اولا ساتسفاكشن انه بيخرج بعد العمليه بشهر تقريبا شهر ونص، بيحصل مابينج في البرين يبدا يحرك. ثانيا بيعمل نفسه فيزيوثيرابي ما يحتاج حد يعني. فاذا جاء النيرف بعدين اشتغل وكذا زياده خير يعني. ما جاش النيرف مع الساتسفاكشن انه يقدر ترجع على التندونوسيس بوزيشن يعني ويمشي.
اذا ما اشتغلش احنا بنكمل التندون ترانسفير بعد. اذا ما اشتغل
تكمله بس انت اعطيتها نتيجه مبدئيه، اعطيتها رضا يعني.
احنا عملنا اللي هو مكان السبلنت
فلكسور كاربيدياليس الاكستنسور
مكان الاكسترنال سبلنت
بالضبط
اللي بياخذ لونج تايم. الان احنا خلاص وما عنده انترنال سبلنت من داخل، وبالتالي محتاج انه يلبس الاكسترنال سبلنت سواء 3 اسابيع فقط بدل ما هي 6 شهور وكذا. الشيء الثاني اذا ما حصلش ريكفري للنيرف بنرجع نعمل له التندون الكومبليت تندون ترانسفير. بنرجع نفتح الانسجن الثانيه حقنا اللي هي الفليكسور ماسل تو ذا اكستنسور عشان نعمل الفينجر اكستنشن.
بالضبط. ثانك يو فيري ماتش.
There's a question from a doctor from Nicaragua, Marvin.
طيب لو رجع العصب هل ينفع انك تلغي التندون ترانسفير ولا لا؟ لو رجع العصب بعد ما يرجع العصب هل تلغي التندون ترانسفير ولا لا؟
No, there is no functional deficit.
ما في فانكشن.
No, because we are talking about partial tendon transfer in the area. No, عملت نيرف ريبير مثلا وانت expected انه يعني will recover. Maybe not. Okay. We do tendon early partial tendon transfer. You perimeter tetanus extensor carpal diaris brevis. هذا احنا just extension. This will cause no disability for the patient because عندنا perimeter two muscles, perimeter teres and perimeter quadratus. وبالتالي البرونيشن حق البيشنت there is no affection at all. اذا ما النيرف ما مشاش وما حصلش ريكفري بعد كده بنكمل حقنا التندون ترانسفير. هذا في الايرلي طبعا. اما في الليت اللي بيجي اصلا بدون ريبير وبعد سنه وما تحسنش احنا بنقوم على طول دور التندون الكومبليت تندون ترانسفير.
Yes, we have a question from, do you see the question in the chat box?
الراديال نيرف انجري في الارم at the arm level.
Yes.
يعني انا اقول الاخوان الزملاء في العظام يعني المفروض مع كل عمليه فراكشر في الارم يعني يا هو نفسه يكون قادر على فصل النيرف اول وبعدين يعمل مانيبيوليشن للعظم، يا يدعي النيوروسيرجن او يعني اللي يدخل معه يعني اكسبلوريشن.
Yes.
حجم الحالات اللي بنشوفها بعد الفراكشرز يعني لا تعد، واحيانا يكون مش ذنب الجراح يعني هو عمل عمل الصح ما له اي دخل. البون فراجمنت نفسه المفروض شو بيسبريتد بيفور يعني.
هو دائما يا دكتور البيشنت هو المفروض انه تيم وورك زي ما قلت الهيومرال ستراكشر بالذات في السيتويشن اللي احنا موجود فيها البيك تروما اللي بتحصل زي ما قلت اطباء العظام اللي يعملوا النيرف سيبريشن او يكلم النيوروسيرجري يجي يعمل له واحنا نعمل له تندون ترانسفير او حتى العظام بيعملوا تندون ترانسفير الايرلي تندون ترانسفير يعملوا عشان الكلام اللي ذكرناه.
Thank you, Doctor. We have one question from the chat.
Yes.
That was the next lecture.
Yes, for Mervin, a neurosurgeon from Nicaragua, what is the percentage of failure in traumatic radial palsy?
What
Did
is
you
the
get that question?
failed in traumatic radial palsy by Dr. Marvin Delgado?
Percentage of what?
Percentage of failed in traumatic radial palsy. Failed operation. Or failed recovery.
هنا it's very high. very high because the
Radial
trauma-
palsy.
Yes,
Radial
radial
palsy.
palsy, yes, radial injury. Hina is very high facial percentage because of the type of trauma. The type of trauma is usually not direct nerve repair.
شكرا جزيلا دكتور بشر على هذه المحاضره والشيء بالشيء ذكر نرحب بالدكتور علي السماوي والدكتور عبد الدور القدسي استشاري العظام بهيئه المستشفى الجمهوري. دكتور بشير معيد لك سؤال فقط. How many cases you have?
Really more than 50 cases. Really more than 50 cases.
50 cases.
50.
So, we
we
didn't see any case. We see one case or two cases.
Just for time, just for time.
يلا okay, thank you دكتور.
Thank you very much, Dr. Bashir. It was a great presentation. Now we will have Professor Omar Youssef, Professor in Neurosurgery at Ain Shams University from Egypt. Professor Omar, are you there? Can you
Yes.
hear me?
Yes.
Okay. You can share your screen. Good.
Okay. You need to put it in present. There you go.
Okay.
Perfect, perfect.
Bismillah ar-Rahman ar-Rahim. I would like to thank the Yemen Society of Neurosurgical Surgeons for this nice virtual meeting, and deeply appreciating their efforts to prepare this meeting under these tough situations. And we, all of us, we should support them and encourage them. Thank you indeed. My topic today is about the use of the percutaneous endoscopic interlaminar approach as a versatile technique. We should here differentiate between the minimal invasive surgery and minimal surgery, as you see from this picture. The minimal invasive surgery must have the criteria of minimal access, minimal tissue trauma, and the most important, it must achieve a maximum cure. That's why this is the most important differentiation between a minimal low profile surgery and a minimal invasive surgery. There's quite big difference between the two issues. Between 1998 to 2014, I worked on 1,000 cases. Now we reached more than 15,000. Do you hear me? Do you hear me? Hello?
Yes, we hear you.
Okay. Between 1998 to 2014, I worked on 1,000 patients. Now we reached more than 1,500 patients working using the PLD technique, the diameter between 14 to 18 millimeters. Why it is a versatile? Because you could work through only uniport technique, reaching a double level only through a small hole, starting with the unilateral one level, then working on the vertical axis of the endoscope to reach the other level up or below, removing all disc materials and navigating in all corners to remove all the fragments without leaving any fragments behind, as you see here in these pictures. Why it is versatile? Because you could use it in either the double level unilateral or bilateral to reach
Dr. Omar. June, you can hear or no? Or only me? You are muted, June. You are muted.
That's okay. Just keep going. It's the Wi-Fi that's getting slow.
Dr. Omar is out.
That's okay. His Wi-Fi stopped. He'll be back. He'll be back.
Okay, we'll wait. No problem.
The digital coffee break.
Is he in yet or no?
He'll be back. I'm sure he's trying to get back in.
We'll wait for a few minutes. If not, we can start.
Yeah, okay. Okay, we'll just wait a few minutes. I'm betting on him.
Hello,
There
Dr.
you
Omar?
go.
are you hearing me?
Yes.
Now we hear you.
Continue, please.
Okay. As you see from these pictures, we could reach by using the uniportal bilateral for one level to target two targets, the ipsilateral and the contralateral, or to reach for two levels, reaching four targets, two ipsilaterals and two contralateral, or to use it as a biportal for four levels, reaching eight targets. That's why it's quite a versatile technique. You could work only through a very minimally invasive techniques to do a multi-task surgery as a minimally invasive techniques. As you could see from these video clips, showing how we could remove all the disc fragments very easily and very effectively, just using the endoscope and shifting along the vertical axis and the transverse axis. Why it is versatile? Because you could deal effectively and safely with a large disc, either in the ipsilateral or in the contralateral. As you could see from these video clips, here we are in the ipsilateral, removing the disc materials. Here we are in the contralateral from only one port, removing the disc material from the contralateral side to relieve the contralateral root. Here removing a huge disc. As you could see from this picture, op and post-op pictures, looks very nice post-operative. It is a very effectively and safely when you work with these types of ultra huge and huge discs only through this very minimal uniport technique. You could see here how you could remove these large disc materials quite easily and safely, very effectively and very nicely here in the in these clips. You see here, we are removing a quite large disc materials. You see here the huge ruptured epidural disc stretching the coda very broad and stretching up and down, remove all the disc material from the epidural space under the coda and preserving the coda, preserving all nerve roots with using this very nice technique and effectively and safely. When you see here the picture and all this clip, the pre-op and the post-op pictures. Another option for this technique, you could deal very safely with a far lateral disc. As you could see from here, we're removing a large disc fragment from the subligamentous area. Then after finishing these subligamentous, you thought that you remove the old disc, but when you navigate to the far lateral space, you could remove another huge disc materials was hidden in the far lateral. With the advantage of the endoscope here, you could remove this another fragments from the lateral corner. As you see here, I'm removing here the subligamentous part. I thought I could finish the surgery, but when I shifted to the far lateral space, you could see a huge, another huge disc. It could be missed in this patient. That's why the recurrence rate with the use of the PLD, it's quite low. Just in my cases, between 1 to 1.5% in 500 cases. Another example, you could use this technique in ultra huge recurrent disc. You could see here, this is cases of the recurrent disc, dealing with the endoscope, making a dissection, removing and cutting the adhesions, try to remove huge disc materials from here. It's quite large. Here's a recurrent huge disc materials and fragments. Here also another huge disc materials in a recurrent case. Here you could see it's quite large in a recurrent case. You could remove it very safely and very effectively. That's why I vote for this technique and called as a quite versatile approach or technique. It could be used very safely and effectively in a multiple challenging cases. These cases are quite challenging cases. This one here, there's a huge subcaudal ruptured disc in a case with a very abnormal root just on the disc space. You could not go at the shoulder. I had to go to the axilla and at the subcaudal area to dissect in the subcaudal area. Here, this second example, to use it in 3 levels, 4, 4, 5, 5 is 1, 5 is 1 disc. You could remove it. You could remove a 3 disc levels. Very effective, very easy. Here, the third one here is quite a very interesting case. After removing here a big fragment at the subligamentous, I have to search and navigate to the other corners. Here I try to remove all the subligamentous and the subcaudal disc materials. You could see still another big disc fragment there. Here still there another big fragment. I'm trying to remove all these fragments, leaving no residual disc materials at all. It's still very sticky, and you need skills and move the endoscope in all corners to be able to remove these huge disc materials. As you see here, try to remove another residual fragment, still another fragment materials. Here I'm removing the subligamentous part, and I thought I have finished the subligamentous part. I tried to navigate. I found another huge material disc fragment here at the axilla between the root and the coda. You could see here a huge disc fragments between the root and the coda at the axilla part, which means it's quite effective and easy, safe approach to deal with different types of disc materials at a different location as well. Here the root's quite free, no more any residual fragments there. We could use it in another challenging cases here, an ruptured amalgamated disc materials creeping on the posterior dura and coda, like a tumor. That case was quite difficult to dissect the disc materials without doing any injury to the root of the coda. As you could see here, I removed the amalgamated part. Then I am now going to the subligamentous part, removing the residual of the subligamentous part. Now the root is quite free. Then I would shift to the second level. That in this case has 455S1 disc materials. Here I'm trying to remove these subligamentous disc materials. I found another fragments at the anterior dura. Here, see with me, quite amalgamated to the anterior dura, and it's quite difficult to dissect it and remove it, as you see here. But with the advantage of this technique, actually you could deal very safely and very effectively when removing this amalgamated part to the anterior dura here. As you could see here, this part still sticky and adherent. I'm tried very gently to remove this adherent large fragment. Still there. Now have been removed totally successfully and safely, and the root, as you see here, is quite free and safe and intact. Sometimes the technique could be overestimated. As you could see from this case, it was a recurrent huge disc materials. The adhesions was quite tough, difficult to excise. Here, as you see, I trying to find any plane for dissection. Try very gently. Then endly and finally, I succeed to reach the disc level here. As you see, opening the capsule.
Hear me?
Yes.
5 minutes, please.
Okay. Yes. 5 minutes. Okay. Removing this disc materials from here, as you see, removing ultra huge recurrent disc fragments. All these are still fragments. You could see here from here, fragments, another fragments, until we could make sure there's no more fragments. And I thought from this case, I had removed all the disc material. However, this patient developed 2 weeks post-op ascites. This R was 160. Then with a broad spectrum antibiotics, cured, and ESA became 20. Here the post-op MRI 2 weeks and 4 months post-op. And I could say here there is no 100% successful approach ever. This technique is quite versatile technique, that you have a good, very nice, good, excellent prolonged follow-up. As you see here, this 1 year and then 12 years. There's another case of 4 years post-op after a large disc fragment. That's however, it's not a piece of cake. Sometimes we face complications. Sometimes we face a complication as a dural tears, especially in cases with a ruptured recurrent disc. This case is quite interesting. Here I'm trying to remove a disc, but yes, suddenly I faced a herniation over a root. Tried with the endoscope, very gentle, pushing back the root very gently here, very gentle to push it back using the magnification of the endoscope here. Pushing back the herniated root. Now it's quite inside the coda. Then I should put a fat graft and then multiple layers of gel foam. The patient post-operatively was very nice without any CSF leak or any more complications. My conclusion, the PLD technique or approach have the advantage of preserving the motion segment and stability in a case of version disc prolapse or a recurrent disc. It offers the use of implants in a recurrent disc, which improve the stability, which preserve the stability, which avoid the cost effect of the implants and the other complication of the adjacent segment disease. It offers one port for two spine levels, either bilateral sides to reach two targets or four targets, or for two or four levels to reach and 8 targets through only 2 ports. It offers a shorter hospital stay with a rapid return back to home and work. The complications still there, however, they are few, comparable, and curable. And that's why I could say the PLD approach is a quite versatile approach. We are preparing all these last 10 years, all these workshops on the endoscope, either ventricular, spine, endoscopy, and this was the last one in this May through the Egyptian Society of Neurological Surgeons. Thank you for attention, and thank you for this effort to prepare this very nice meeting. Thank you.
Thank you very much, Professor. Very nice presentation. Thank you very much. We have one question in the chat by Dr. Marvin Herman Salgado. He's asking, what is the minimal size of incision during your approach?
Yes, it's very important. That's sometimes some surgeons, they work using 25 diameter and they say it's a minimum invasive. My approach uses either 14 millimeters or 18 millimeters according to the levels. For the 2 levels approach, I use 18. For 1 level, I use a 14 millimeter.
Thank you, Dr. Omar, for this presentation. And my question, by this approach, can you do contralateral disc plus or only ipsilateral?
Sorry?
Can you do contralateral disc prolapse by this approach?
Yes, as I explained here, there is a technique which called uniportal bilateral, that I go from a unilateral port dealing with both the ipsilateral and the contralateral in the same situation from the same port with the same approach. But it needs a learning curve. I'm working this more than 25 years. It's called an advanced technique and needs actually a learning curve.
My question about what the difference between the irrigated interlaminar endoscopic irrigated or dry irrigated endoscopic, and how can be reached to level by irrigated endoscopic.
Your question, you asked me how I could reach a 2 level from 1 port. You mean that, right?
No. About dry as we see in this that's cases, all maybe used dry endoscopic. But
No, it's not a dry. It's not a dry.
Endoscopic, can you reach to level and bilateral or no?
No, it's not a dry. I'm using always continuous irrigation by the hands of the assistants, to
But,
make just
there is difference in irrigated and dry endoscopic. Maybe you used EasyGo or Distando Distat approach. In this case, that's
no.
case.
I'm using now the EasyGo system in the last 10 years. Before I used the metrics, but now I use the EasyGo
tubular system.
And this is not a dry. I'm using irrigation by the hands of the assistant due to the montage of videos, just to explain only the important steps. However, I use the continuous irrigation by the hands of the assistant.
Okay, but there is difference between the irrigated endoscopic interlaminar and the discectomy can not reach to level or but in Distando or EasyGo can reach to level. There is difference or no?
You mean the full endoscopic, the difference between the full endoscopic and my approach? Yes? Yes? Do you mean that? The difference between the full endoscopic approach and my approach?
Yes.
Yes, the difference in the full...
Also full endoscopic, I know. But what the difference between irrigated, full irrigated, and this approach? Maybe this approach is easy and...
my approach...
all different or all types of discectomy by the EasyGo, but the irrigated endoscopic cannot using in all the type of discectomy.
My approach needs a little bit learning curve for any surgical approach all over. However, I could use my approach in all types of disc. After 25 years experience, I could say that I could remove all types of disc in the all corners, in the far lateral, in the subligamentous, in the posterior epidural, in the anterior epidural. You could use it very safely and very effectively to remove all types of this. However, it needs a learning curve.
Thank you. Good lectures and good videos. Thank you very much, Prof.
Dr. Omar.
Yes.
How are you, sir? Thank you very, very much. I was with you in Academia Al-Amira Fatima before 2 months in your great and very nice workshop.
Welcome. I could remember you.
It is a chance for me to thank you again and again, you and all our...
Thank you. Welcome at any time.
Teachers.
Welcome at any time. Welcome at any time.
You're great, man. Thank you very much.
Thank you. Thank you. Thank you.
Thank you, Professor Omar. Thank you, Professor Omar.
Thank you very much. Thank you.
And we are honored to have you with us in our conference.
It's my honor. It's my pleasure.
Thank you very much. Now we will move to the next speaker, Dr. Salah Sailan Ubaid and Dr. Muhammad Saifullah Abu Hamra. They will present presentation about the role of orthopedic surgery in management of cerebral palsy.
Good morning. Before I get started, I want to clarify that the cerebral palsy is not specific disease. It's an umbrella term for a group of disorders that affecting the mobility of the patient. Okay. Aim of our presentation is to review quick facts about cerebral palsy and discuss the management option and orthopedic consideration in the treatment of the cerebral palsy. By definition of the cerebral palsy is a disorder of movement and position of the patient due to affecting of the motor system. It's resulting from permanent and non-progressive damage to the brain before 2 years. الذي مقصود اللي هو immature brain. The insult should be occurred before 2 years. The primary insult اللي هي brain damage is مثل ما شرحنا permanent and non-progressive. السكندري باثولوجي اللي بتحدث في الموتور سيستم هي اللي بيحدث لها progression during يعني with time until skeletal maturity. As we said before, primary lesion or brain or neurological insult in the immature brain, resulting in in abnormal muscle tone, impaired sensation and balance, and weakness, and leading to spastic muscle. Spastic muscle, as we know, spastic muscle with time, with longer standing, is converted to fibrosis and shortening. This is with time lead to mismatching between normal growth of the bone and abnormal growth of the muscle, leading to bone deformity and subluxation and dislocation of the head. يعني بالمختصر مشكلة البرين is permanent and non-progressive. المريض بيشتكي من المضاعفات الناتجة عن الإصابة هذه والتي تحدث العضلات، تحدث لها قص وتشوه في المفاصل وديفورميتي in the bone. وهذه المشكلة التي بنحاول نعالجها في المريض. Spasticity in the first, it can be treated by neurosurgery with muscle relaxation. But when the spasticity convert from dynamic to spastic and contracture, it is the job of orthopedic to prevent the deformity of the joint of the and the bone. As we see here, the secondary pathology is contracture. Okay. The contracture, when we convert from dynamic to static, this is the job of orthopedic to prevent upper and lower deformities, spine deformities, foot deformities, and gait deformities. Also, we see that the cerebral palsy, we have high chance to get fracture due to osteoporosis and osteopenia. Again, هنلخص اللي هو first brain insult lead to spasticity والذي في البداية بتكون dynamic. يعني correctable. البيشنت can move the joint with difficulty. After long standing المصل بيحدث لها fibrosis وshortening وبيحدث اللي هو fixed contracture with difficulty of movement. في هذا المرحلة احنا بنفعل tendon lengthening. More long if the patient is ignored without treatment, contracture will lead to bony and joint deformities. وفي هذا الحالة بنفعل soft tissue release مع osteotomy. طب معنى الكومن سايد فور muscle tightness بيكون في اللور limb في flexors and adductors of the hip, flexors of the knee and plantar flexors of the ankle. في الupper limb معنى pronator of the forearm, wrist and fingers flexors and thumb adductor. طب what's the common site for bone deformity؟ في السباين معنى السكليوسيس، الهيب معنى dislocation subluxation. التيبي والفيمر بيكون معنا اللي هو البون ديفورميتي تورشن والفوت بيكون فيه اكوينس. As we see in this picture, this is a patient. نشوف الكونتراكشن في الهيب والني والفوت and in the upper limb. Cerebral palsy is also associated beside the motor impairment. It maybe has some of impairment like fusion, speech, epilepsy, and this is dealt with our colleague in neurosurgery to treat it. There is various factors, causes for cerebral palsy. 1/3 of the cases idiopathic with unknown cause. Other causes, peri and postnatal. The most important two factors are the low birth weight and low gestational weight, especially when the patient weight less than 1.5 kilos. The chance to get cerebral palsy is very high. In fact, we have here strange paradox. Improvement in the health care, في هذا الحالة الانسيدنت, improvement in the health care يوازيها increase in the incidence of the cerebral palsy. How? Improvement in the intensive neonatal care, this is reflected in the increased survival rate of the low birth weight, TB and premature. هذا eventually في الأخير بيزيد increase in the incidence of the cerebral palsy. We have here paradox. Also in the in vitro fertilization, numbers may be increased. This is lead to increased incidence of the premature and low birth weight, and eventually increase the incidence of the cerebral palsy. Clinical evaluation of the cerebral palsy by clinical examination by detailed history about the patient before the birth and perinatal and postnatal, and also take the history of the developmental motor. The role of the neuroimaging is very important and recommended to establish the structural damage of the brain, but not always it is not always it's okay. يعني some cases the MRI is normal and 12% تقريبا normal, so the clinical picture are not always match the imaging. طب من اول بنتكلم على الموتور ديفلوبمنت. ما هو الموتور ديفلوبمنت؟ نورمال موتور ديفلوبمنت معناه جزئين اللي هو نورمال موتور مايلستون بلس نورمال ريفلكس ديفلوبمنت. النورمال موتور مايلستون في these اللي هو heat control at 3 months, sitting at 6 months, crawling at 9, standing at 1 year, walking between 1 year and a half. Any delay in this time, this is mean delayed motor development. هذا يبدأ نشوف إنه الحالة cerebral palsy. The second part of normal motor development is normal reflex development. As we know, the patient delivered with primitive reflex. This is reflex disappear at certain time. معنى المرور reflex يختفي في عمر شهرين 3 شهور. Palmar reflex from 2 to 3 months. Rotating reflex 3 to 4 months. If this reflex exists, this means abnormal reflex. على طول نشوف في موضوع السيربرال بالسي. وليش ذكرت انا هذا الموضوع؟ This is for early diagnosis of the patient with cerebral palsy. كيف نشخص المريض في المراحل الاولى بعد الولاده؟ The cerebral palsy should be the patient have delayed motor milestone and abnormal reflex development. If there is delayed motor milestone with normal reflex, this is not CD. This is other entity, other disease, metabolic, other neurological disease. This is not cerebral palsy. Should be both affected. Classification of the cerebral palsy is very important. We have 3 main classification. Physiological classification, it depends on the site of the lesion. Certain area in the brain develop certain pattern of the cerebral palsy. If the cortex of the cerebral is affected, spastic, وهو the common style from 98%. If the basal ganglia is affected, dystonia and dyskinetic. If the lesion in the cerebrum, this is mean imbalance and ataxic. In fact, there is no pure pattern of the cerebral palsy. يعني غالبا هو بيكون mixed بس في prominent lesion than the other. Second classification according to which part of the body is affected. If one limb, mono, one side homo, lower limb diplegic, quadriplegic for 4 limbs, and triplegic for 3 limbs. The third classification is very important for us. Why? It's describe the ability of patient to walk and predict the prognosis of the disease. بنحاول نتوقع حالة المريض في المستقبل. طب في classification هذا we have 5 little. The first 3 واللي هو the common type البيشنت بيكون ambulatory يعني بيتحرك. Last 2 اللي هو 5 4 و5 patient non-ambulatory. طب it's very important to take some little details here. The level 1 patient nearly normal. Level 2 patients walking but يعني أغلبية الوقت without assistant. Level 3 also patients walking but most of the time is with assist device. Level 4 patient طبعا can walk little step بس غالبا بيكون بالبولتشير وبيكون self mobility بيحرك نفسه. الليفل 5 هذا totally dependent in all كثير اسبكت يعني ترى مستوى حركه رقبته يحتاج سبورت. طب هنا في الفيجر هذا this is figure very important for us. This figure is explain the natural history of the cerebral palsy. As we know, with increase the age of the patient, the motor development or the motor function is improved, as we see, and reach the peak at the age of 5. يعني المريض of the cerebral palsy without intervention, surgical or clinic, already بيحدث له improvement up to the year of the 5 and 6. After that plateau to the age of 7, then we see the motor function there is decline, especially in the class 3, 4, and 5. This is decline due to rapid growth of the patient and increase the weight plus weak muscle. فالمريض بيبدا الان يبدا يشتكي من مشاكل. فاحنا as orthopedic surgeon بنحاول نفعل السيرجيكال انترفنشن ان ذا ديك اللي في سن 4 إلى 5 سنوات. قبلها بنحاول نفعل بوست بول لان البيشنت اوريدي بيحدث له ايش؟ بيحدث له امبروفمنت. وايضا اي تدخل جراحي قبل سن 5 سنوات الريكرنس ريت is very high. So we try to push the surgery up to 5 years. وتكون قبل 7 سنوات لانه اذا حدث له ديكلاين خلاص قبل الكونتراكشر والديفورميتيز ستارتد. Prognosis of walking. We have good prognosis for walking يعني مؤشرات ان المريض يمكن يمشي. الجود prognosis اللي هو head control by 9 months, sitting by 2 years and floor mobility by 50 months. الباد prognosis for unwalking. توقعنا ان المريض هذا ممكن نقول والله هذا صعب او مش ممكن يمشي اذا ما مشي اذا ما حركش راسه في 20 months. There is no self sitting ما يجلس على 4 سنوات and not walk by 4 سنوات. هذا توقع انه المريض ما عاد يمشيش حياته كلها. طب management. I have 2 points here. The management of the cerebral palsy it's multidisciplinary. يعني it's multidisciplinary team means people are involved in both the planning of treatment, decision making for this patient. A multidisciplinary team is not doctor. It's يعني contain a pediatrician, a neuro, orthopedic, physiotherapist, family, also the teachers, psychiatric. هذا كلهم بيتخذوا قرار علاج المريض. طب treatment of the cerebral palsy. علاج الcerebral palsy يعني شو بدك اللايف it is not just walking. الحياة مش يعني في قصص success history. Patient was seated and got success in his life. Otherwise بنلقى مرضى يعني ناس ماشيين كل يعني اقتصاد رياضية ومكان في السجن يعني. ف treatment of the cerebral palsy just not working. We have respect the patient child priority to life normal features, how to learn him to communication, education, and how to build patient independence. نعلمك كيف يعيش حياة مستقلة، يأكل نفسه، يلبس نفسه، ينزل نفسه. الموضوع مش قصة إنه يمشي. Third one mobile. كيف يتم تحريك المريض؟ آخر interest أو concern in the treatment of cerebral palsy is injury. كيف نحاول عملية تحريك المريض. It is the last one. بعكس في ال parents priority اللي هو بيجي يكلمك دائما في العيادة الدكاترة الموجودين يكلمك على الووكينج. والموضوع أكبر من just walking. Treatment general principles of the cerebral palsy يمكن ملخصها في التالي. How to keep function range of movement by physiotherapy, maintain the position by orthosis, splinting, and how to assist patient walk by assistive device. Also decrease or control spasticity, general by baclofen, regional by selective dorsal ectomy, specific by botulinum or botox injection. Last one, corrective deformity. This is our job orthopedic to deal with this by soft tissue tendon lengthening, muscle lengthening, or bony procedure by osteotomy. طب مثل ما شرحت الاورثوبيديك تريتمنت سيرجيكال نون سيرجيكال اللي هو نون سيرجيكال اللي هي سباستي كنترول اوريدي شرحتها. طب في الوضع هذا يهمنا انه يعني ما نكونش مسرفين في استخدام الريلاكسنت دراجز يعني اللي هو سباستي كنترول لانه في الاخير spastic muscle is better than flaccid weak muscle. Surgical treatment. Aim of our surgery is to correct deformity, improving walking pattern, prevent bony and joint deformities have at an early stage. In the late stage, you are dealing with complications like bone deformity and joint dislocation. Treatment or surgical treatment is different from patient to patient. مش كل المرضى بياخذوا نفس العمليات نفس الإجراءات. It's different. In class 1, 2, 3, اللي هو البيشنت يكون walking. The aim of our surgery is to keep the walk as efficient as possible. يعني ايش؟ التدخلات الجراحيه الرسمه اللي توضحها بس هنا. التدخلات الجراحيه هي بتحسن المريض at the same level. يعني ما فيش تدخل جراحي او علاج بينقل المريض من ليفل الى ليفل. يعني الى ليفل 1 نو. انت تحسن المريض في نفس الليفل. فلذلك احنا بننتظر لسن 7 سنوات 5 سنوات لما نشوف الباترن. المريض ما قالوا فيه. التدخل الجراحي بعد ما نشخص المريض والتريتمنت اسيست بيشنت at the same level. ما بننقله. It's impossible. تنتقل في حاله واحده. if there is wrong decision بتنزله من مستوى الى مستوى، اما رفع impossible. حنخلص goals of treatment. As you see in goals in ambulatory patients differ than
the time please. You have 2 minutes.
non-ambulatory. The goals of our surgical is to keep patients sitting as comfortable. The indication or orthopedic surgery, fixed contracture, joint dislocation, rotational abnormalities, shows wear problems, pain, and perineal hygiene. Now, time of surgery, as we said before, postponed to 5 to 7 years until walking or gait pattern develop. طب في حالة واحدة ممكن نتدخل قبل 5 سنوات. There is one exception if there is a structural abnormality. يعني في joint dislocation like hip or there is severe contraction of the muscle like knee flexion, severe knee flexion. ممكن نتدخل جراحي نطول على الأساس patient can walk. But type of surgery, we have soft tissue linked to the muscle and tendon and bony osteotomies and joint occlusion. As you see here, السيرجري مثل ما قلنا principles our surgeons كل الcontracted muscle والاوستيوتوميز should be done at the same نسميها single ended multi level surgery. بتعلم كلهم في عمليه واحده، مش تقسم كل شهرين وتر كل شهرين عضله، لا. من البرنسبلز our intervention you have to do it in single event multi level surgery to prevent complication and prevent يسموها بريسبي syndrome ان المريض كل شهرين في العمليات. طب as we see in the hip we have we do lengthening for psoas and adductor muscle in the knee medial hamstring in the ankle Achilles tendon upper limb. طبعا الانديكيشن وغالبا في lower limb. الانديكيشن في الupper limb معناه hygiene procedures ولا increase the function في patient لما يكون حد الاي كيو between 50 or 70 or higher. طب في النهايه so what does orthopedic surgery have to offer؟ بنفعل link tendon, transfer tendon, relocate joints, rotate bones by osteotomies and joint fusion. Thank you.
Thank you, Dr. Salah.
شكرا في كثير من الاسئله، ممكن نسمح سؤال او سؤالين. دكتور احمد شريف الدين.
Thank you, Dr. Salah. Thank you, Dr. Salah, for your presentation. You see in your left in presentation, MRI, brain MRI is normal in. Okay. If the MRI there is lesion in the brain, what do you do for this patient? Can you do orthopedic operation or no?
In fact, the order to take MRI is still by neuro, not by us. غالبا ال MRI اللي بيطلبه دكتور نيورو is not orthopedic. As you said, we are dealing with
microphone.
As orthopedic surgery we deal with secondary effect. يعني لما قد المريض دخل في secondary pathology. البرايمري باثولوجي اللي هي spasticity وطلب الام ار اي هذه غالبا بتكون بالنيورو تقريبا نيورو. احنا نادرا ان احنا بنطلب زي ام ار اي.
Okay. Second question: if there is another with if there is AMD nerve condition velocity there is abnormal, also you do operation for patient or no? AMG and nerve condition velocity is. If there is problem in the muscle problem.
Spastic. Doctor, in the spasticity, dynamic spasticity, we don't never do operation. This is treatment by muscle relaxant physiotherapy. We are do operation when there is spastic and contraction and fixed joint. احنا بنتدخل في المراحل اللي يبقى في deformity يبقى في stiff joint وفي loss of range of movement. اما في حاله اللي هو السباستيستي وتخفيف الدماغ هذه by our colleague in neuro. احنا بندخل في المراحل النهائيه لما يكون في fixed contraction in the joint and loss of motion. ولا في النون ambulatory patient بنتدخل اللي مثل ما قلنا comfortable sitting pain hygiene الحدث الذي ايش؟ ده في مشاكل على المريض، ما ينفعش تدخل جراحي انه يقوم يمشي.
دكتور يعني if we have lower limb spasticity and we talk in these days about bomb infusion or يعني Koodman bomb يعني for baclofen from the spinal cord to abdomen. What you think about that?
About baclofen bomb?
Yes.
Okay, as we say, this is treatment of muscle relaxant or spasticity control. We refer patient to specialist doctor like neuro and pediatrician doctor or vegetarian by decision to introduce the spastic control by authority.
Okay.
Already we refer this patient to specialists like neuro.
Thank you very much, Doctor. Due to the limited time, we will allow only one more question by Dr. Ahmed Sharif, and the rest of the questions will be asked by person.
Excuse me, but what do you mean by me? You will do all operations for upper and lower limbs in the same sitting?
Yes. الآن بينصحوا انك تفعل كل اوبريشن at the same level. ليش؟ على اساس تفعل كنترول ماسل بالانس. اذا فعلت مثلا انكل المريض بيكون في مشاكل جرافت شنكيت something like that. فانت يفضل انك تفعل all the muscle at the same time to keep the muscle balance around the joint. Yes. No, all lower limb كامل ممكن تفعله. اذا في الابر ليم يمكن تفعلها. بس اللور ليم غالبا تفعلها at the same level. ليش؟ تحافظ على المسل بالانس، لانه لما تفعل جوينت الفكره الثانيه يا برضه المسل بتاثر يعني المريض بيدخل في other complication. السكند بيشنت اوستيوتوميز. الاوستيوتوميز وين there is يعني الموضوع تطور من مسل كونتراكشر وفيكس جوينت الى بون ديفورميتي. بون ديفورميتي ايش؟ بيحدث باوينج للجوينت، بيحدث روتيشن، دوسلوكيشن، المفصل يخرج. احنا بنحاول نكسر العظم، نعمل روتيشن، نزيد كفرج اوف ذا اسيتابلم، ونتدخل عظميا اذا جت في مشاكل في العظم. اما اذا الموضوع محصور بس في كونتراكتد فيكس ماسل بنفعل للمسل السكشن.
شكرا دكتور صلاح، صراحه محاضره رائعه وظلمنا ان الوقت قليل عليها للامانه. Now we will move to the next speaker, Professor Ali Ibrahim, Assistant Professor of Neurosurgery at Ain Shams University. Dr. Ali, are you with us? Please unmute.
Yes. The problem is I have a lot of noise in my headphones. I don't know if you can hear me.
Yes, we can hear you well.
We can hear you.
If we can fix the noise.
We hear you very good. We are hearing you very good.
Yeah, I am having noise in my headphones.
You can't hear.
Yeah, now it's better. Now it's better. So, good morning. Assalamu alaikum. I am Ali Ibrahim. I am an assistant professor of neurosurgery at Ain Shams University in Cairo, Egypt, and it's definitely my pleasure and honor to be participating in your conference. And hopefully next year I'll be able to physically participate by coming to Yemen myself.
You can share your screen.
Yeah, that's what I'm trying to do now. Just a second. Okay, can you see the presentation now?
There you go. You need to be in present. They're perfect. Perfect. Got it.
Thank you so much. So today I'm going to discuss the role of intraoperative ultrasonography in as a routine adjunctive tool in resection of intrinsic brain tumors, and I'm going to try to make the case for ultrasonography. Now, I have no disclosures. Now, as we all know, as neurosurgeons try to push for perfection, they're trying to attain a maximum resection of brain tumors. At the same time being safe, it means preserving the function of the patient. And this is definitely can be fulfilled in both metastatic brain tumors, the most common brain tumors, and in primary parenchymal or intrinsic brain tumors, especially glioblastoma. Now, we know that in lesions like glioblastoma, there are multiple factors that affect the outcome, including age, Karnofsky performance score, molecular factors like IDH, extent of tumor resection, and adjuvant treatment. Among all these, only extent of resection is a surgeon modifiable factor, and every effort should be spent in this regard. Now, we do have adjunctive tools to achieve higher extent of resection that has been used extensively over the past 2 or 3 decades, including frameless stereotaxy or neuronavigation, intraoperative real-time images, like intraoperative ultrasound and intraoperative MRI, and tumor-specific contrast like 5-aminolevulonic acid and non-specific contrast like fluorescein. Of course, intraoperative neuromonitoring may allow for more tumor resection when the problem is not tumor delineation or visualization, but rather proximity to eloquent areas. Now, frameless stereotaxy is a virtual image depending on preoperative images. It's excellent, it's very useful, but it's also hampered by intraoperative brain shift, either due to tumor resection or debulking and CSF leakage. But it's still very useful to plan the craniotomy before the bone removal. Intraoperative MRI, on the other hand, is the highest resolution image, has the highest sensitivity to detect residual tumors. But first of all, it's not really real time because you have to stop the flow of surgery, get an image, and then get back to surgery. It's definitely very expensive, that it's a luxury even in high income countries to have in the operating theater. It requires special settings, special training, and also it significantly increases the time of the operation. On the other hand, ultrasound, which has been used, by the way, for more than probably 30, 40 years, but then kind of lost some interest after the introduction of frameless stereotaxy. It's real-time image, it's easy to use, it's relatively cheap, and it has excellent localization of intraaxial tumors. But I think the main advantage that makes many neurosurgeons not use it routinely is that neurosurgeons are used to interpret MRI images. They're not used to interpret ultrasound. So what I'm trying to explain today is that with some changes and some training that will not take a lot of time, this can be corrected. And neurosurgeons will find it very useful as an adjunctive tool for brain tumor surgery and also for other indications. Ultrasound can also be combined with navigation, as we are going to see. And this has a reciprocal benefit. So ultrasound is a real-time image. It means it can correct the shift errors in navigation, but also looking at the navigation, the superimposed navigated image, surgeon can better understand the image he's seeing on ultrasound, especially if he's not used to ultrasound that much. Now, for the role of ultrasound in resection, traditionally, resection of intrinsic brain tumors goes through these steps. So performing craniotomy, and then tumor localization after bone removal, stages of tumor resection, assessment of the extent of resection or completeness of tumor resection, hemostasis and closure. Now, 3 of these steps, we can use ultrasound: tumor localization, control of resection, and assessment of completeness of tumor resection. Now, in tumor localization, we have found, and we have started using ultrasound in 2012, that intraoperative ultrasound can locate almost all brain tumors, irrespective. And localization, just telling me the tumor is there without seeing the boundaries, just the tumor is there. It also can identify tumor margins, in most cases very well. In traditional surgery, without using guidance, once we open the dura, traditionally, we would rely on things like here, like changes in the cortex to identify the tumor, right? But in many cases, we also find cases like this. We open the dura and the cortex is completely normal as the tumor is subcortical. And then if we don't have navigation and if we don't have ultrasound, the next step is simply exploration based on preoperative calculations. But in that case, and these 2 cases, by the way, are some of my cases, and they have a strikingly similar MRI, but the cortex look different in them. So using ultrasound in this case, we were able to localize the tumor to this area of the cortex. So now we know exactly the boundaries that's within this gyrus, posteriorly bounded by this cortical vein. Of course, in this case, we also had to add intraoperative monitoring because the tumor was in proximity to the motor area, as we can see. The second thing an ultrasound can do is to delineate the margins of the tumor, giving us a better idea of where to start. We can see that some of the tumors has a very well delineated margins here, indicated in blue arrows, or partly here indicated also in blue arrows, or poorly defined images, either due to technical problems or due to actual problems with edema or tumor consistency, like we see in red arrows here. The third stage is tumor resection. So as we see here, there's this hyperechoic tumor. And as we progress through the resection of the tumor in these stages, we can see and assess how much we have removed from this tumor until this stage. And then finally, which I think is the most important function of intraoperative ultrasound, is to assess the completeness of resection. How much have we resected the tumor? Interestingly, this paper came out in 2012 from a respected institution, and it was able to demonstrate that in almost 70% of cases in which the surgeon intraoperatively perceived that he has done a gross total resection, in 70% of these cases, a residual tumor was demonstrated on postoperative MRI. So in many cases, we think based on tumor consistency, based on the color of the tissue in front of us and the consistency of the tissue in front of us, that we have removed the whole tumor, but in many cases we have not, and they're still residual. So going back to the idea of extensive resection, that a more extensive resection would lead to a better or a longer survival for the patient, this is a lost chance. So for example, this tumor here, I've already gone and delineated the margins of the tumor, and we can see areas of cystic degeneration that is helpful also in introducing the tumor to the surgeon. Now, after resection of this tumor, we introduced the ultrasound probe inside the tumor cavity to assess for, and this is a magnified image of the tumor resection cavity. This is just of the resection cavity, and we can see this hyperechoic residual, which might have been blood, but actually we have removed it and sent it to a separate pathology, and it turned out to be tumor. Another thing is the relationship of important structure to the tumor can also be visualized through ultrasound before reaching these structures by the microscope. This image may seem difficult to someone who has not used an ultrasound, but let's try to simplify it. If this is the normal T1 image of the T1 weighted MRI image of the patient. So first of all, we have to imagine the image in this orientation, because this is how the patient's sleeping. And the probe is coming from here. So we're going to magnify this area. This is what we're going to see. This is the uncus. This is the crural cistern. This is the interpeduncular cistern. And this is the midbrain. We have the same thing here. This is remaining tumor in the uncus. This is the midbrain, and it's usually hypoechoic because of less water content, because of the dense white matter inside. And we can see using the color flow here, the basilar artery and the posterior cerebral artery, which is important to identify when we're resecting medial temporal lesions, even in epilepsy cases, to know exactly how much tissue we have left until we reach the pia of separating us from these cisterns and these important vascular structures. Now, we have gone a long way from using a very simple ultrasound in an endoscopy cover like this and a glove and some optic gel inside, to using a state-of-the-art ultrasound that is made for neurosurgery that can be sterilized and used directly on the brain, and using navigated ultrasound at the same time. So this is, on the right is the setting that we do now. On the left is the old setting. Now, this is an illustrative case to illustrate that. This is a 57-year-old male patient who presented with confusion and mild left-sided weakness. Apparently, most of his symptoms were due to shift and edema, not directly invasion by the tumor. Now, we took this patient to surgery. And as soon as we did, the patient was in a prone position. And as soon as we did put the ultrasound probe on the dura before opening the dura, this is what we saw. So to be able to correlate this with MRI, we have to put the MRI in the same orientation as the patient sleeping in the prone position with slight tilt of the head. And the probe was put in this area here. So we can see here, this is the tumor. This is the interhemispheric fissure posteriorly here, okay? This is the ventricle of the contralateral side here. and this is the choroid plexus inside the ventricle on the other side, just zoomed. So remember that MRI is made in three positions: axial, sagittal, and coronal. While ultrasound, the position is variable based on how you put your probe and how you use it. So if you orient yourself in the same way as an MRI here, you can start to understand the image better. Now, this is the case I demonstrated before. It's from that same patient. It's assessing the extent of resection as we are going through the resection phases. This is a magnified image using the probe at the very deeper part of the resection cavity, which is, again, this part here. Okay, remember, it was very close to the ventricle. So this is the tumor cavity. This is a small hyperechoic rim that is seen in most resection cases, does not necessarily indicating tumor, but this is an actual nodule immediately above the ventricle. And in this case, we decided not to remove this because we already had more than 90% resection, because breaching the ventricle has been shown to have a bad prognostic effect on that patient. And again, we see the falx, the ventricle, and this is a small residual tumor. Now, this is the post-operative MRI of the patient. This is the non-contrasted, and this is on the left is the contrasted MRI, and we can see a clean resection, exactly like we saw it in the intraoperative ultrasound. Now, our initial experience with ultrasound at Ain Shams University was published in the Egyptian Journal of Neurosurgery. And the results after the first about 50 cases was very striking. We had two groups comparing traditional resection to ultrasound-guided resection, and we found the difference is huge. Here in light purple is the ultrasound group, in dark purple is the control group. Here on the left, we are comparing in terms of gross total and near total resection. It means resection is more than 90%, and we can find a huge difference with a significant difference. More than 50 or 55% of cases had a gross total or near total resection. While here, we can see how a subtotal resection was much higher in the control group in which there was no ultrasound. Again, this might be to nodules that are hidden in between tissues, or because of the crumbling of the resection cavity, the surgeon was not able to see it, or the surgeon saw it and thought it was gliosis and not tumor. This is a quick reference to how different lesions would appear on intraoperative ultrasound in terms of echogenicity and the ability of localization and margin demarcation. We will find that, and this was a strange observation, all tumors that had good contrast enhancement in preoperative MRI were hyperechoic and were well localized in ultrasound. I don't know what's the physics behind it, but this is how we found it. High-grade gliomas, metastasis, abscess, low-grade gliomas, localized low-grade gliomas that had a solid part like pilocytic astrocytoma and pleomorphic xanthoastrocytoma had a well-localized hyperechoic ultrasound image. On the other hand, cystic lesions were also well localized because they were hypoechoic. And imagine hyperechoic and hypoechoic, just like we discussed in MRI, hyperintense, hypointense, and so forth. Low-grade gliomas, on the other hand, were the poorest to localize. So I would not recommend to just rely on ultrasound for low-grade gliomas. They can still be used. They generally will give you the idea where the tumor is, but the margins will not be well delineated. So in these cases, again, navigation will be used, and if available, intraoperative MRI. Now, this is an example of a cystic tumor with mural nodule. In these cases, if we're not using navigation, we can go into the nodule, the cyst would crumble, and we would not be able to see where the nodule is, which is the main aim of surgery. Now, the cost of IOS varies greatly. I am advising of buying an ultrasound device within the budget of the institution. It's better than not having an ultrasound at all. We have most of our series at the beginning, the one that was published, was done through this very simple ultrasound device. It's a portable GE general device, not specifically made for surgery, and the images were good. Now we're using this BK system, which is honestly one of the best systems in the market. And it has probes specifically made for neurosurgery. As for the probe choice, I always recommend a small microconvex probe because it gives a broad idea, even if you're going through a small craniotomy that has multiple frequencies. So frequencies from 5 or 6 megahertz up to 10 or 11 megahertz. This is the actual probe on the left that we were using at the beginning. And then these are the new probes that we're using with the BK system. Some of them are convex and burr hole probes with also the possibility of navigation with these localizer stars.
Dr. Ali?
Yes?
We have 2 minutes, please.
This is the conclusion. Now, to conclude, ultrasound is cheap, flexible, easy to use tool that should be available. It's an adjunctive tool, but it should be available in neurosurgeons' armamentarium. It's excellent in depicting contrast enhancing lesions on preoperative MRI, cystic lesions, and even hematomas. And then the more you use ultrasound, the more you're going to expand the uses of the ultrasound. In intrinsic tumor resection, it helps in tumor localization, margin delineation, identification of some important relations, including the ventricles and important blood vessels, and identification of small tumor residual and subsequent removal. The problem with ultrasound is neurosurgeons are used to interpret MRI images, but with some training, they will be able to interpret intraoperative ultrasound. They don't have to be radiologists. They don't have to be ultrasonographers. They don't have to understand the exact physics behind ultrasound. And you will find that the more you use ultrasound, you realize how useful it is. And then you're going to expand this to others like non-neoplastic lesions of the brain, including cavernomas, abscess, hematomas. Spinal cord tumors is very useful, but it's not the scope of our presentation. Ultrasound guided biopsies, guided shunt insertion, especially in pediatric cases who have still a fontanelle, and also in cerebral vascular cases. Final message is that although most brain tumors probably in the future are not going to be treated mainly in the operating room, probably in a lab or through a targeted medication, but until then, maximizing tumor resection and minimizing surgical induced morbidity, continue to add these small increments of improvement to things that matter most to our patients, including survival and functioning. And that every effort should be spent in this regard. We should not just take this lightly and just depend on the old technique of biopsy followed by radiotherapy as long as the tumor is resectable. And I think this is all. Thank you very much.
Thank you very much, Professor Ali. It was a great presentation and very interesting. I thought there is many questions, but now we have Professor Ghazi Yasarjil, the father of modern neurosurgery and macro neurosurgery, here joining us now. Thank you, Professor Ali. Professor Ghazi. Professor. Now we can start with Professor Ghazi Yasarjil, the father of modern neurosurgery and micro neurosurgery. It's all yours, Professor Ghazi.
Salaam alaikum, dear colleagues in Yemen.
Wa alaikum salam wa rahmatullah wa barakatuh.
I did like to introduce my lecture with this unique plate found in Baghdad with an old antique writing. Read it. The sciences may taste bitter for the beginner. Later they taste more sweet than honey. As you see, I am still working in my age and I cannot leave it. It's a wonderful plate. Next, please. In 1949, as I made a medical board exam, I went to Professor Eugen Ludwig and told him, we learned a lot of anatomy in the extremities and in abdomen, but we didn't have a chance to work hand-on on brain. He was very serious and said, yeah, but you know how expensive a brain is. But if you came extra, would like to be neurosurgeon, we will help you. He wrote this book. It's a very excellent in German anatomy book, neuroanatomy book. with excellent tables. Next slide. And I took from backside the drawings and make a copy, give the color, and make a copy. I like to make it, take it in my hand, and I can learn, I can help my memory better. I can imagine better. So I made from this book, this model of the spinal brainstem and cervical spine. Next slide, please. And then Dr. Kringler was in the next room, and he was told by Dr. Ludwig he should told me about the brain. So I spent 3 months in the anatomy in Basel University and learned how to dissect. There is an atlas from Kringler and Ludwig. Is excellent atlas about the fiber system. Next, please. This is what I made myself after 3 months, how it looks. In 1990, Dr. Suture from Istanbul came and saw what I am doing. And then this was in my library. And he was impressed. And he said, how do you make this? I said, okay, you have to go to Basel and learn this frozen cadaver brain technique, and then you can dissect it. Next slide. He made X dissections, and I hope once a day he will bring his fantastic dissections in another atlas. Next slide, please. Then, 1953, I started in neurosurgery, and Dr. Cranville asked me whether I can do it. Angiography, percutaneous. I said, I will try, sir. And then I was successful. This was very essential for my career. I started to do carotid and then vertebral angiographies, percutaneous, high local anesthesia. And we published in German the vertebral vascular system, then cerebral angiography book containing both. And what I'm showing here, we made two series. We moved the camera 5 degrees from lateral, 2 pictures, from anteroposterior, 2 pictures. So we had a stereo picture that we could observe on this unique instrument. This apparatus was bought by Dr. Cranberry in London. This was used by artists, and nobody used this. We could put 2 different axis pictures. In the middle is a mirror, and you can move it. You have the feeling you sit inside of the brain. See all the vascular system, especially in case of arteriovenous malformation or by vascular tumor. It was a fantastic to observe. This is not common. I don't understand this. This is very essential to be at home with the brain neuroanatomy, parenchymal, and also vascular anatomy. Next slide. Here, you see, we could look here in the middle and then study every person individually, adjust the mirror system. Next slide. Now, look, we had also these systems to look these stereo pictures with this, but the other was better. Next. Now, what is the microsurgery? Microsurgery is this, the secret. The average pupillary distance is 63 millimeter. if we have to work in narrow gap cavities, then it's difficult to see stereo. We see monoscopic. We don't realize this. Next. Under the operating microscopes, under the object, there are two small objects. They are only 16 millimeter apart. So we can work in a smaller gap. We don't need 5 centimeters. We can work in a just 1.5 centimeter. Next slide, please. And Zeiss company developed 1953 this excellent microscope, operating microscope. And we changed it. We made this microscope more mobile. I had one mouthpiece and I could move it. It is counterbalanced like a feather without any weight, up and down, forwards, backwards, and around. This was essential to work continuously around the brain because the ophthalmologist in ENT people may use this microscope very well, but the brain is a very complex anatomy. We go around the brain down, and it's changed. We have to change our axis. Next slide. Like here, you see here, right-sided Sylvian fissure, and then you see the carotid cistern and the chiasma cistern, and down there, posterior communicating cistern. There is a very special architecture of the basal cistern. We have to know this, and I published this in my papers and books. You have to look there. You have to learn this. Next slide. Then you will be at home without sacrificing any vein and arterioles. You can explore along the Sylvian fissure down to foramen occipital. Down. Next slide. Just here. This young person, one branch of the middle cerebral artery is occluded. We open the Sylvian fissure without damaging the normal structure, and then resect it and clean the segment and put some 20 single seizure. And you see on this picture how it looks now postoperative. Next slide. Or in this case, 3 arteries are occluded, only left vertebral is open. And this gentleman, and his engineer, by turning his head, he had a problem. He could fall down. And I said, we have to do a bypass. This gentleman was at that time 62-year-old, and he was the first human who became intracranial bypass. Next slide. You see here, we made him this, and interesting, this small artery get after a while larger, and it take the responsibility to vascularize more areas. He didn't get any problem. Before he had a problem to turn his head. Next slide. Now, we use the micro technique since 1967, and by aneurysm, by ABM, by other malformation, and then by tumors, intrinsic, extrinsic. By aneurysm, it is not enough just put the clip, make remain a rest of aneurysm. So next, this is here a large aneurysm here, on the anterior communicating, we can put temporary clip only for 2 minutes. And in this time, deflate, coagulate, next. You see here, coagulate it and put 1 clip. I don't put 3-4 clips for large analysis, just reduce the size. And all the perforators are very safe. Next. Also in the microsurgery volume, you can see all this type of the vascular malformation. Mainly we operated some 700 brain AVM and 100 spinal AVMs. And then there are other types. I don't like to enter more here. You have to read yourself. It's well documented in the book. Next. Here, we had an excellent neuroradiologist using the endovascular approach. Here, he tried to catch the left frontal basal medial AVM, but he called me and said it doesn't like to inject. So I had to explore myself. Next slide. And we could, it was not easy. Nothing is easy. We could remove it. And it looked like this postoperative. Next slide. Cavernoma have been known to elder generation, but we get more and more with the MRI when they occur more in brainstem, and also in spinal cord. And I operated altogether some 200 cases. Next slide. Just to see, it can be removed well. Next slide. This patient is intact. Next. Main instrument is by surgery, microsurgery is the bipolar coagulator, which was available. Dr. Malish, he created this, and we changed a little, but then it worked very well without any sparks. And it is very excellent. Without bipolar technique, we cannot work with it because the operating field has to be very clean. Next. And we created this forceps line. We cannot make a microsurgery only with 3 forceps because it goes down sometimes very deep. To hold the forceps for a long time, we made the holes on forceps. You don't slip. The surgery sometimes takes 3, 4, 5, 6 hours. And each length had 4 different tip size. Next slide. And this is maybe not known. This was produced by Malish. This is a bihemispheric coagulator. With this, you can go up higher level of coagulation, and by vascularized tumors, especially meningiomas, this is very important. We got the one example, unfortunately we lost Malish very early. I don't know who is producing this. You have to think about it. Next. Next. Finish it. 1000. Shown in the game. There were the tumors there.
From both.
Moment. Okay, Joy. Next. I published first this volume, small microvascular surgery, invited many colleagues working as the pioneers. later our experiences, next, and then for the aneurysm, 2 volume, next, for the AVMs, another, and for the tumors, another, altogether 6 volume. You have to catch these volumes because it contains exact information, detailed information about outcome statistics and all operates, and everything is there. I am sorry, your library may have these books. There are some information about several thousand operated patients. Next slide. Here. This is the AVM. The other one was the tumors here. That is what I have to tell you. Thank you very much for listening.
Thank you
Okay.
very much. We are very honored to have you with us presenting in our conference, and it's great pleasure and honor for us all. Dr. Gazi, can you hear me? Professor.
Bizi duyuyor musunuz diyorlar hocam. Bizi duyuyor musunuz diyorlar.
I hear very well. I like to add the microneurosurgery was very essential to operate most so-called inoperable lesions in AVM, aneurysms, and in tumors, intrinsic, extrinsic, and the mortality came down under 0.1. It is well documented. You can study. I am listening to your questions.
Doctor, we have some questions for you, and we are like to have a group photo with you. Is it possible?
Group photo.
The whole
Group photo.
they are all standing. We can have a group picture with you, Professor. Is that okay with you?
Yes, say yes.
Fotoğraf çekecek,
Yes,
sizden
yes,
izin
yes.
istiyorlar.
You sprechen.
Nein, photo.
We are all standing in the hall, so we can take group picture with your photo. Is that okay with you, Professor?
Yes, okay.
Sir, yes, okay.
Yeah, he wants to take a group picture.
Weißt du, man kann über Computer fotografieren. Und die wollen wissen, ob du einverstanden bist.
Sure.
Yeah.
Go ahead, Ahmed.
We will take a group photo with you, Professor, okay?
Okay.
Ohne Brille.
You know, my eyes get worse and worse are my hearings. I don't hear very well, sorry.
Go ahead, Ahmed.
I need helper here around me.
Because look up because you're looking. Du schaust nach unten. Schau nach oben.
Biraz yukarı,
Yeah,
kamera
yeah,
burada hocam. Biraz yukarı bakarsanız daha
Yeah.
yüzünüz çıkacak. Heh.
Yeah.
Onlar da şurada bakın görüyorsunuz küçük ekranda. Bütün kongre orada. Resim çekecekler ekranda.
Okay.
No, wait a minute.
I am no more operating since 8 years, but I am working on the last volume.
Thank you, Professor. Everyone here is standing in the room. We have a group photo with you, and everyone is thanking you for joining us, and we are very honored to have you, really.
Shall we now?
Hey, take the picture.
You know. Yeah, better. Yeah, now they are taking, stay still, but die machen jetzt das Foto.
Okay.
Now we'll open the questions For Professor Ghazi, anyone have any question?
Now's your chance.
Dr. Ghazi. Professor. خلاص يا شباب لو سمحتوا بس هدوء عشان نسأل الدكتور ياسر جيل قبل ما نمشي. Anyone have any question for Professor Ghazi? Ayman? Dr. Muhammad have a question?
I don't understand any question.
No. It's coming. Come.
Dr. Ghazi.
Niemand hat sich gemeldet.
Go ahead with the question.
Dr. Ghazi, can you hear me?
Yes.
Okay, sir, my question for any neurosurgeon who is beginner, who has very strong interest in vascular microneurosurgery. What's your advice for us?
Ja, die wollen hast du Ratschläge? Hast du Ratschläge für Neurochirurgen, die vaskuläre Chirurgie machen? Hast du Advice?
You have, if they, first of all, we have to learn the osseo craniospinal anatomy, then the meningeal, then the cisternal, then the vascular anatomy. I spent a lot of time. I worked 12 years as neuroradiologist and performed several thousand carotid vertebralis angiograms. And we observed this in our apparatus stereoscopically. And we gave this in the book with Dr. Kreinbühl. There is a full data about anatomy and the statistics. You have to catch this book. But there are other books, also Huber from Bern, he's a neurosurgeon. He wrote the second edition of this book. It's also excellent. And you can look whether you can catch these books or to study. You have to study these books and then yourself, you have to make the models. It's my way.
Thank you very much. Thank you very, very much.
Professor, what's your advice for new young generation neurosurgeons, especially in Yemen, where there is limited resources? What's your advice for them?
Die Frage, was würdest du jungen Neurochirurgen sagen, aber die wenige resources haben, limited resources?
We have spent time in our profession to learn. I have been almost 10 years resident by Dr. Kreinbühl, helping him, watching what he's doing. And this time I studied a lot of anatomy and made the angiographies. And this I'm recommending read the publication, serious reading, studying, and try to find good models. Did you ever see such a model? This is another, doesn't smell. This, I don't know what material. This is made in Germany by a genial person. You can open and study the brain here in every sulcus. lateral sylvian and the medial, each part. This is a Mr. Axel Lang. What is he?
Zurich University.
Axel Lang.
Ja, und er hat ein Website.
Dr. Axel Lang has a website. So, Mrs. Yashargil, look here. This is a small brain. How precise is made. You can study.
Okay, this is nice.
Later. You have in your hand, you can put in your pocket. It is a little expensive, I may say, but I had this always in my table or in my pocket to check it, to learn more. There is no end to learn. That's it.
Thank you, Professor. We have also many questions for you. Dr. Ayman, you have any question? Anyone have any questions for Professor Ghazi? Everyone stand up so we can cheer for Dr. Ghazi and thank him for joining us in our conference. Everyone, please stand up.
Jetzt hat sich nochmals bedankt und die Leute stehen auf und klatschen.
Thank you, Professor.
Yeah.
Thank you guys for the honor and for joining us in our conference. We are very having you. Thank you, Professor.
Thank you.
Doctor, do you have any word for our conference, please? Do you have any word for the neurosurgery in Yemen or for the Yemeni Association Neurosurgery? Do you have any word?
Any parting words, Dr. Ghazi, for the Yemeni neurosurgeons? Any parting words?
Besonderes sagen am Schluss deinen Vortrag als Gruß oder.
Dear colleague, I am still daily working several hours on my next volume of neuroanatomy. You will have some surprises there. Human brain is different, and humans are different. This is my thesis, and I like to show this. I studied some 200 brains, the cerebral gyral variations. From there, I entered in this topic, and you will see what I am bringing a surprise.
Thank you very much. And we are looking forward for your next book. And we are honored to have you. Thank you. Thank you very much, Professor Ghazi.
Thank you, Professor. And
thank you, Professor.
See you in the next year in our Congress. Thank you very much.
Thank you. Thank you. I appreciate very much you invited me.
Thank you. Now we will have Professor Salman Sharif from Pakistan for the next speech. Professor Salman, can you hear me? Professor Salman still after 10 minutes. Okay, we will have a brief break, 10 minutes break, and we'll come back after 10 minutes. Thank you, everyone. John, you can hear me, John?
Yes, okay. 10 minutes break.
10 minutes break, okay?
Okay, we'll see you in 10 minutes.
Okay.
Takashi, you there? Does anybody want to say hi? I'm getting bored here in Miami. I hope this is not going to the whole auditorium. Or is it? Well, Dr. Lawton was glad to see the room full of neurosurgeons. Oh, yes, you are. You can hear. Well, maybe it's not appropriate for me to be talking to the whole room. But that was a golden moment with Ghazi. That was really nice. Well, the med students are here, Shamsidin. Med students are here. Where are you from, Shamsidin? You can talk if you want. Is Takashi there? Oop, I think Ahmed's going to tell me to shut up. Oh, Martin, how you doing? Come on and say hi, Martin. Martin from Germany. We're just chatting with members of the panel. Oh, Nigerian studying in Uganda. That's excellent. Excellent. As you know, studying medicine may be an itinerary, maybe it's a profession that you can travel all over the world.
كيف غير الكاميرا قلت لي؟ جون.
Yes, hi.
هذا يسمع من هنا ما يسمعش.
To whom do I have? Oh, Martin. Is this Martin? Is this Martin?
مفتوح. هو بيسمع بس انا شو اسمه واضح هنا.
انا مغلق الصوت هنا.
Okay.
John, can you hear me?
Yes, I can hear you.
How is everything until now?
Well, that was a magic moment with Yazi, huh?
Yes, yes. Everyone in the room was coming up next to the screen so we can have group photo. So Group Ghazi was wondering, where are they going?
Yeah, I didn't know what you were doing either. I'm trying to figure out how we're going to do that. You know, looking back on it, I probably should have just taken a camera shot of the audience. You guys are all standing there? Yeah, so.
I can't hear you very well because the sound man is not here and I can't hear you very well.
Oh, okay. I don't know if I got it. Did you get it?
فين عبد الرحمن؟ فين حق الصوت؟ فين حق الصوت؟ ايش عيد اي واحد منهم ما ينفعش يخرجوا كلهم. احنا عندنا دحين دقيقتين ثلاث بدينا. تصل قول يجي لا.
Well, I got to show Dr. Lawton the audience.
Dr.
so-
Salman is already in or no?
I'm sorry?
Dr. Salman, he is in.
No, I don't see him yet. You better text him. You got his WhatsApp or whatever?
Okay, I think he's in.
Oh, no, I don't see. Oh, there he is. No. Oh, there he is. You're right.
How are you, Professor? Unfortunately, I can't hear you now. We are
Here
waiting
he
for
is.
the
He's coming
sound
in. He's
man.
coming in.
So he prepare. عبد الرحمن صوت حق صوتيات. قول له يجي هيك. Dr. Salman, we should start after 3 minutes.
Hi, how are you?
How are you, Professor?
Not too bad. How are you?
Thank you
doing?
for joining us, Professor. I know you are busy, but thank you for joining us.
A great job.
It's a great pleasure for us, Professor.
It's really my pleasure to be here.
We should start after maybe 2 or 3 minutes, okay?
No problem. I will just get my earplugs.
Okay.
Bye.
और भी सारे devices
Where is it? So you need to make this small. नहीं खुलता नहीं.
Professor Salman, how are you?
Not too bad. You look good. How is everything?
Professor Salman, can you hear me?
I can hear you very well.
Okay. We can start now. What do you think?
I can start now, no problem. Whenever you think it's right, we can start.
Professor Salman for joining us. It's great pleasure, and we are welcoming you to the 4th Yemeni Neurosurgical Conference. Now we will have a presentation or talk by Professor Salman Sharif, Professor in Neurosurgery in Pakistan. He will give us a presentation about future directions and robotic in neurosurgery. Dr. Salman, you can start. It's all yours.
Thank you very much. It's really my pleasure to be a part of the 4th Yemen Neurosurgical Conference. As always, our friends have had a wonderful program, and I'm really honored to be part of it. We know that a robot is any programmable, reprogrammable powered manipulator with artificial sensing that can assist in a variety of surgical tasks. The first application was in neurosurgical use was way back in 1980s when we had a Puma 200, I'm just going to go back here. Delicate neurovascular structures and narrow neurosurgical corridor limit the expansion of robotic surgery in neurosurgery. So this is a classification of surgical robots that we have at the moment. So for example, Davies, position controlled, active and passive. And then we have role-based, so intern replacement. So it serves as a substitute for an intern, telesurgical, neurosurgical aid, navigational, precise positioning, precise path. And then we have role-based again, which is passive, restricted, and active. Depending on function, then it's dexterity and precision location. And again, another classification, which is a similar classification as well. So different types of robots that we have available. So passive robots only serve as tool handling devices once directed to the desired position. For example, you take an endoscope and give it to the robot would hold it in its place. Then you have got semi-active devices which perform the operation under direct human control. Example, in a compliant mode. And then you have active devices which are under computer control and automatically perform certain interventions like bone machining. The systems that are able to perform fully automated processes such as CT-based biopsy or cutting are called autonomous. So they are supervisory controlled. A human supervisor is there, but the person does not intervene unless if something goes wrong, then they intervene. So you give that biopsy task to the robot and robot does that altogether. So passive, semi-active, active, and autonomous robot. If the robot is entirely remote control and the surgeon is in charge of every motion of the robot, we call it teleoperated. So it's like Da Vinci that we use many a times. The application of robots in neurosurgery, spine, stereotactic biopsies, skull base, and future applications are neurosurgical technological laboratories and cadaver labs. So there are lots of new things coming, and we are excited to hear about those things. So robotic surgery, why do we need it? Obviously, history of neurosurgical intervention in stereotaxy and navigation has been there for a long time. The tight anatomical confines armored by a robot could be extremely beneficial. Procedures are microsurgical, highly technical. The growth and need for growth in minimally invasive neurosurgery and a culture to adopt and embrace new technology with optimism. What about cobot surgery? So it's a limiting factor, not the lack of creativity, vision, desire, or captivity, that rather the inherent complexity of most neurosurgical operations. So cobot surgery is robot assisting in surgery and delicate part of the operation. So like step of anatomical localization, stabilization of the surgeon's hand during prolonged microsurgical work or targeting of a pedicle screw. So this is now routinely practiced. In the future, it may be necessary for not just, but several robots assisting in completing a routine neurosurgical procedure, such as craniotomy for tumor resection or lumbar spine fusion. So this is what we'll be thinking in future direction. Design, obviously, there are problems because the tools are rigid, which is most common in spine and endoscopy. And then there are curved tools, which are transnasal approaches, biopsies, and endoscopic craniotomies to minimize minimally invasive stuff and to reduce recovery time. This can be compromised because of its size and strength and the stress the tool is under. So triangulation movement and overcrowding of the space are a problem with robot at the moment. So how can we improve this human-robot interaction? So we can bring in hepatic feedback. So just like we feel when we are operating and we get the feedback, and then we can decide, oh, this is a structure and I'll take this. So if same kind of feedback will be given by a robot, and then you'll be able to know that this has happened. So for example, the difference between a bone and a ligament. So you'll be able to get that feedback as well. Force sensing, strain gauge, and optical force measurements. Then you can have proprioceptive feedback coming from the robotic arm, and kinematic, it's amplification and filtration and visualization via CT, MR, endoscopy integration. So there are multiple things that have come into play in robot with the recent advances. And the training, if you do that in virtual reality and preoperative preparation of a virtual OR, so you rehearse the surgery beforehand with the robot, in an augmented reality. So stereotactic brain biopsies, robots, state of the art, the future is already here. So if you look at these number of studies that we have out there, frameless robotic assisted stereotactic biopsies for lesion of the brainstem, series of 103 consecutive patients, robotic guided platform for laser interstitial thermal ablation and stereotactic needle biopsies, then pushing the boundaries of accuracy and reliability during stereotactic procedures, prospective study of 526 biopsies comparing the frameless robotic and image guided systems and accuracy of robot and frameless stereotactic neurosurgery in a phantom model. So this thing is already happening, and these studies are already out there in last couple of years. So this is really a good beginning for neurosurgeons in practice, and young neurosurgeons should be looking at it with a lot of grace that we are going into a different race altogether. So, for example, this interstitial thermal ablation is stereotactic needle biopsies. So this is a picture taken from their study, whereas another study showing thermal ablation therapy and stereotactic biopsy at the same time. And the evolution is just going on and on and on. So there's market and training trends. They push medical system towards the use of robot in spine surgery. There is restriction of work hours, so less trained spine surgeons are expected to do more and more. Robots could allow for increased safety. Currently, spine robots act as a guide to help position tools into an ideal position or trajectory. So for example, putting in a pedicle screw or a lateral mass screw or a C1, C2 screw, these are the screws that we are routinely doing our T-lift procedure, for example. So what about the ideas in future? Use of robots that are passive but provide no-fly zone around protective structures such as dura, robotic laminectomy could be the way forward. So the gloves with motion sensors, so they would allow for robots to follow. The robot comes in as an intuitive robot and capable of handling higher forces in spine surgery or more complex manipulations of the tissues. So automatization of simple procedures such as wound closure could be done by a robot in future as well. Current use for assisted pedicle screws, K-wires, screw misplacement can occur up to 8% of the time when you're doing freehand, and this can be reduced to 0.2%. First robot of spine surgeries was way back in 2004, in which these pedicle screws were inserted. Various systems of different kinds are available, and every one of them have an advantage over the other for a particular reason. But we need to be looking at one robot we could do, which could function in various ways and improve our cost. So that is important for us. So robot pros, obviously reduction of operative time, reduction of wound surface and wound healing deficits, high accuracy of screws or anything that you're putting in, and decrease in revision complication rate, and application with CT and O-arm, intraoperative CT and O-arm is there. Obviously, sometimes when you're starting out, you've got learning curves, so longer operative time. Registration and installation issues are there, and sometimes they could be problematic. Learning curve, no improvement of surgical efficiency at the moment over time. So if you look at this evaluation of robotic guided minimally invasive implantation of 2,000 pedicle screws, 413 surgeries, 9 misplaced screws and 7 patients. So screw accuracy of 97% in these 2,000 patients. So obviously, and none of these screws which are misplaced required to be revised. So if you look at this, another study in which in 2021, they use a Mazor robot, 5 to 8 times lower risk of surgical complication with 11 times lower risk of revision surgery. Surgical time was similar between robotic guided and freehand surgery as well. So another study, which was a single center study using O-arm neuronavigation with Mazor, they found no difference in the reliability of clinical acceptable screws. Infection rate, intraoperative blood loss, and operative time, there was no difference, although there was significant effect on both precision and accuracy according to the Gasvin-Rabin screw placement. The age of active robots for pedicle screw placement is already here. So initial intraoperative experience is robot-assisted pedicle screw placement with circ, robotic alignment, and evaluation of first 70 screws. This is a friend of mine, Mirza Botkat, who actually helped me in this study as well and making this PowerPoint presentation. So he came up with this paper recently. And the question is, does robot-assisted navigation influence pedicle screw selection and accuracy in the minimally in his spine? So now with all that confidence, we are able to use greater size screws, greater length screw, and a similar kind of high accuracy. So everything is improving with time when you're using robots. So in spine, at the moment, we are unable to decompress, decorticate, or to place rods or contour them. But the time is coming very fast that we'll be able to do this in near future. The future is really bright. The safer and more thorough decompression could be an option, and that could be done once the robot is trained in a particular way, navigated and automated osteotomies for deformity, and incorporation of artificial intelligence components facilitating smarter operations. So MRI-based navigation could enable soft tissue handling, including disc work, tumor resection, skin closure, cage implantation, could all be done via robot in near future. They have been increasingly utilized for spine tumor resection, radiofrequency ablation, and osteotomies and deformity surgery, and it's already there. Manufacturers are actively working on creating lighter, more portable, and more affordable robots, which can function in various ways, do the cranial and spine, and do all of them in order to increase their accessibility, usability, and to have a comprehensive package with lower cost. The incorporation of artificial intelligence into these robots with low latency 5G connectivity in order to allow a surgeon to be able to operate remotely. So you could be sitting 1,500 kilometers away, and the delay during your performance and the act that happens is just down to 10 milliseconds. So what about augmented reality versus robot and augmented reality in addition with robot? So this study looked at 11,000 patients receiving 20,000 screws. Robot-assisted instrumentation was associated with less risk of inaccurate screw placement, fewer operation. All that was shown before in the prior study, same was shown here as well. What about augmented reality integration robots? So bed-mounted attached robots to possess 2 or more arms, each equipped with 3 joints, necessary tools to place a percutaneous screw and rod system. So this is already coming. Surgeons could supervise the surgeon either directly or through augmented reality headset. So you wear a headset, and with the help of that, the robot, you guide the robot, and you can see exactly what is going on in the patient. If you merge the artificial augmented reality along with 3D visualization of the 3D screws, then obviously with the handset, you can even project targeted structures onto the patient. What about robotic guided skull-based surgery? Let me just come to the cranial bit. There have been a lot of work done on this, and there is like transmaxillary, transnasal, supraorbital, and transorbital, and transcervical. All these are already there, and these systems are already available. Their use in daily practice is still minimal. Research and studies revolve around endoscopic endonasal approach, and reduction of the size of the robot-assisted system will be the way forward. At the moment, the size is so big that we are unable to bring in those systems into this kind of surgery. So for example, look at this robotic guided skull-based surgery. This is a photograph showing the setup of TORS approach to cellular lesion. And this could be done with a much smaller system than the Da Vinci itself. So these are all these systems that are available, like EndoFix, IARMS, and all of them have been used in cadaveric, and some of them are in the clinical trials as well. Future direction, skull-based surgery. At the moment, current, there are limitations because of size and angulation capacity of the robot, because they're fixed arms at the moment, and the lack of drilling component at the moment in robotic surgery is not there. The cost is a big issue, and we hope that the cost is going to come down dramatically once more and more robots come into play. Obviously, advantages, we have got improved lighting and 3D visualization. There is replication of traditional gesture-based movements and application of dexterous movement, ordinary risk constrained by small operative corridors. What about towards autonomous collision avoidance for robotic surgery in deep and narrow spaces? So this article clearly shows that there are newer and newer gadgets coming out with which we could have more space available for us to work, and the narrow corridors could be avoided. The preclinical development of a robotic assisted ventriculoscopy for 3D image reconstruction and guidance of deep brain neurosurgery. So the Phantom study showed current robotic assisted techniques are fairly limited. So they used the implementation of robot assisted ventriculoscopy system for 3D reconstruction, registration, and augmentation of neuroendoscopic scene with the intraoperative imaging. So once you have all that, you should be able to perform ventriculoscopy and ventriculostomy with the ease. What about in robots in the neurovascular surgery? So this is the first robot-assisted calling, which was done in Toronto in 2019. The animal studies are already in use for a long time, and they're able to show that the evidence is there. The robots will be able to perform much better at the delicate areas of our intervention. Having said that, obviously, at the moment, we don't have autonomous robots who can work on their own, and we need to be careful about the side effects which may be associated with it. With microneurosurgery, obviously, the newer exoscopes, which are 3D robotic guided exoscopes, can help us with various surgeries itself. And various studies have already come out showing that the results are pretty impressive, and we think things are going to improve with time. What about completely autonomous robots? Treatment is not universal, so at the moment we think it's going to be difficult to have completely autonomous robots. Anatomy and medical history differ from patient to patient. Currently, adjusting movement on demand is not yet possible. For time being, stereotactic assisted or equipment positioning alone could be a possibility with robot. Addition of subroutines, wound closure, clamping, basic manipulation could be done by a robot. And this recently, Shekhar wrote on this, the future of skull-based surgery viewed through the tinted glasses, showed that the University of Washington team working on autonomous robotic system showed that intelligent neurosurgical robot assistant. So you have a robot which is assisting you while you're performing your surgeries, or you could have a hybrid system and you can have a human assistant and a robot assistant, and you could be performing surgery and they could help you in this. And this is probably the way forward with the number of juniors going down because of this 48-hour system that we have. Completely dependent endoscopic assisted robots. Future of dependent system will rely on the miniaturization of robotic tools, as I already said, and incorporation of curved endoscopic ports. The shortcoming of small, long parts related to its flexibility, which limits how small each arm can be. So future, smaller robots, smaller arms with two control hands working at the same time. So surgeon would control two of these small arms, and the other two could be programmed to assist via surgeon itself. The future of dependent system rely on these miniaturization, as we have already said. Will robots replace surgeons? Well, a robot performs the first laparoscopic surgery without human help. This was reported in January of this year. It is possible, but there are significant problems that could be associated with it. So you need to be wary of that. So medical robots in China, the rise of technology in 3 charts, they're all over the place. They're coming with the newer, smaller robots. And I think they're going to be a big force in future. Korea's first neurosurgery robot to debut to seek FDA approvals, and you can see another from Holland itself. When robots replace surgeon, so never bet against the human nature. So robot-assisted surgery is blamed for a heart patient's death in UK, where the robot continued to do a procedure and actually damage the ventricle while this should have been stopped. So the problem was that the inquest showed that the surgeon using a robot for the first time, even though he was not trained, and the supervisor had gone out of the surgeon's room at that time. In robotic surgery has been involved in 144 deaths in 14 years. Robotic surgery is on the rise as doctors look to make procedure less invasive, but according to new study, the strategies comes with the risk. So I thank you all, and with this, I welcome you all to World Spine 9, which hopefully we'll be able to have along with Head and Neck Spine Society on November 3rd to 5th. And it was really my pleasure to be part of this webinar. And you're all most welcome to visit Pakistan at some time and look at our amazing northern areas. We recently had a trip to Naga Parbat Base Camp with 17 of our friends from all over the world, and we really had a great time. So it's a pleasure being here. Thank you.
These very nice and precise lecture, and we hope we found in our country recently, inshallah. And I will open the floor for any question. Salman, thank you for this nice lecture. I have only two questions. First,
sure.
Do you do only per hole or small craniotomy when you are performing the robotic surgery?
I think it can be performed both ways, but obviously when you're just doing biopsy, just like any other computer-guided biopsy, you just do a borehole and then robot does the whole thing once you load it up.
And the question, do you use robotic surgery in functional neurosurgery like deep brain stimulations or dorsal root intrusion lesions?
I think there have been some studies on it. We are not doing any kind of that surgery at the moment, but some of my friends have started doing it. There have been a lot of work already on it. So as you know, thermal ablation is already there. So I think it is possible that in future that it will be a big thing which will take this in big way. And I think robots will change the way we practice in another 15 years' time.
Thank you, Dr. Salman. Thank you.
Thank you, Professor. Thank you. It's a great honor for us. Thank you for the presentation.
It was my pleasure. Thank you very much.
Now we'll have Professor Ahmad Kanaan from Saudi Arabia will be joining us. Dr. Ahmad, are you with us?
Yes. Do you see my slides?
Yes, we can see your slides.
All right, I'll put it in presentation mode. Okay. Well, good afternoon. I'd like to thank Professor Saleh and the team from the Neurosurgical Society of Yemen for inviting me for this wonderful webinar. I'm glad to follow my friend, Professor Salman Sharif, who gave us a very nice welcome to his country, a wonderful place to visit. It stays in our memory. My presentation will be on how simple approach trumps the complex one. And this might be provocative for some members, but it was not meant for this. It's my own personal opinion about the evolution in skull-base surgery in recent years. I have listed several names that they have contribution to the skull base. I'm sorry if I left someone behind. At the same time, I put the evolution in neuroendoscopy of several names that they have contributed to endoscopic neurosurgery as part independent or complementary to skull base surgery. 2006, I conducted the Asian skull base surgery meeting in Dubai. And I have invited 44 world-famous skull-based surgeons. You can recognize some of them, like here, Professor Horton, God bless his soul, Professor Sami, Pochi, Spetslav, Kawazi. All of them, they are on this picture. And we took that picture, they exchanged their experience on the emerging skull-based phenomena in the mid-80s and early 90s with all these approaches with the motto more bone removal for the sake of less retraction and better exposure. And these are the approaches: the fronto-orbitozygomatic, the pre-sigmoid approach, and the far lateral represent the a la mode that time in the early 90s. And 10 years later, I conducted the Asian Congress of Neurological Surgery meeting in Dubai. I have put them all in the Arabic style, and the motto was different: less invasive neurosurgery. And that time, the emerging endoscopic assisted or endoscopic standalone surgery became part of the skull-based society, and the trend toward less surgical exposure, because you can compensate with the technology, having the extended arm of visualization of the endoscope, have a better end microscope, and concept of releasing CSF and flattening orbits has reduced the need for the complex approaches, except in some cases where this approach should be not forgotten, to be taught and learned and used whenever it's possible. So as you see, I put the reversal arrow from the complex pre-sigmoid approach back to the retrosigmoid approach, and from the complex fronto-orbitozygomatic to the terional approach. And the two legends, hopefully they have long life to live, and Professor Kazi Yajagil and Professor Majid Sami, they have put the for neurosurgery is the perfection of microsurgical technique. Whatever technique you are using, you have to be a perfectionist in microsurgical technique. And I'm glad that Professor Salman Sharif put the drawback of the robotic surgery. I like to use the motto, somebody has said it, we'd like to have less artificial and more intelligent. And that's what is the concept, that you have focused on more training rather than replacing a neurosurgeon around the world. So how you do it, there are several items I mentioned here, and the functional exposure should provide good functional outcome. This is the motto. And we see example, I'm going to go over the different areas. The transfer surgery was the best example, moving from the complex approach, not pituitary. Rarely we use now craniotomy. There are selective indication for that, but now most of the cases will go transfer whatever the size. And new indication for the extended or like a large supracellular component, dumbbell-shaped tumors, retrocellular expansion, subfrontal extension, all these, they became part of the transfemoral surgery with their complementary extended approach. Factor that still limit the degree of resection is the multilobular configuration of these giant tumors. And this is statistically evident. And the extension to the middle fossa, this will still keep the craniotomy as an indication. I grade the resection of a giant pituitary adenoma and these levels, the nasal level, sinus level, cellular, and supraparacellular level. And I feel in my hand, the phase one, which is the nasal part, I don't insist of having the endoscope for this part, as I will be there in no time at the sinus. And I still like to use the microscope or the speculum. There is no sin by using the speculum for this part, and then keep the integrity of the nasal cavity intact. When I come to stage 3 and 4, this is where I feel the endoscope is a must. And this is an example. This is a transfemoral surgery. We expose the face of the sinus, and then we, from the contralateral nostril, we enter with small incision in the endoscope, enlarge the posterior part of the septum, and then we can take the speculum, do the whole things with the endoscopy, and we see this is the herniated diaphragm after resecting a big tumor, and you see the medial wall of the cavernous sinus. This is where I feel the endoscope is very important for an extensive or near complete resection of tumor. I apply the principle of clock technique. I start from the lower part at 6 o'clock and I go on both sides up. So I initiated dead space where the tumor, the upper part, can herniate it down, and then it will make it easy to remove the rest of the tumor at ease with the space for manipulating the instrument and putting the endoscope 30 degree or 70 degree, whatever you need, to retrieve any residual tumor. These are example pre and post. This was done in a single stage procedure with the giant tumor reaching the floor of the lateral ventricle and face the whole third ventricle. And you see post resection, very good results. And as I mentioned, it's one stage procedure. Some other example, we have a retrocellular component that we could retrieve it. I was guided by this nice MRI. This is very important to study your MRI ahead of time. You see at the top of that tumor, there is an area of an acute infarction with a high signal intensity here. On T1 weighted images, when I guided by this one, when I reach it, I know that I'm on the top of this tumor and put the endoscope 30 degree backwards to get the retrocellular component that was a soft tumor and came out nicely. And you see the postoperative resection. This was done by an endoscopic assist, not by extended approach. So you see how advantage is this one. For cases you are dealing with the craniopharyngioma or other type of tumor, you might need the extended approach. Going to another area of interest, the lateral approach to the frontal and middle fossa. The fronto-orbitozygomatic I restricted only for cavernous sinus surgery or complex aneurysm surgery like the ophthalmic artery aneurysm or some giant basal tip aneurysm. But you see, by resecting the sphenoid wing as described by Yazarji, and flattening of the orbit and release of CSF early in the procedure, you get ample space for a functional exposure for any supra or cellular tumor, tuberculum celli, meningiomas, and planospheroidal meningioma. And this case was done through trans-eyebrow approach. This is what I call it the functional exposure. This is what you need. Expose the area of interest, and this is the tumor of the supracellular meningioma removed, and you see the stalk, optic nerve, and optic chiasm, and left optic nerve. Important in meningioma resection, apply the rule of 5D, which is devascularize, don't come from the dome of the tumor. This is the worst you can do because you lose blood unnecessarily. The red blood cells of the patient, they are as important as yours. So we'll leave to devascularize first the tumor from the base up, and then respect the arachnoid membrane around the tumor, which is your friend, as I always said. This is your natural patty toward the cranial, toward the neurovascular structure, like here, the carotid and the optic nerve. And de-roofing of the orbit, the optic nerve is very essential in these cases, not only to retrieve tumor, that is a common phenomena in tuberculum celli meningioma, that tumor tongue will share the optic nerve in its canal, but to reduce the manipulation of the optic nerve and the tethering of the optic nerve at the level of the falciform ligament. Now, there are several studies that shows that releasing the roof of the optic nerve and the falciform ligament will improve the visual outcome. And in my hand, we used to do it at the end of the procedure. It has no sense. You have to do it ahead of time. And the result of visual recovery converted from a 30% to 70% in these cases, if not more. These are examples pre and op as that brain was not touched. And now we'll go to the hybrid use of the endoscopy. You see, this is a supracellular meningioma. We are removing it through a contralateral approach. I don't want to go from the dominant hemisphere. I have a direct view to the area of the tuberculum celli and under the optic nerve on the left side. After removal, I thought I removed everything. You see the optic nerve and the optic nerve and the carotid. But when I put the endoscope, I visualize the carotid under the left optic nerve, but this is the stalk. And then I realized there is the residual tumor hidden behind that I could not see it with the microscope. This is the value of endoscopic assisted surgery, and this is a pre and post-op complete resection of this tumor. There are few indications, but I am not keen to take a meningioma from below. The only indication, perhaps, according to the classification of Pamir and Al-Mufti, only the diaphragmatic meningioma, which is in a rare occasion. This can be managed from below. But why should I convert a craniotomy into cranectomy? Why I should do less symptom grade resection? Why I should have a high incidence of insomnia, anosmia? Why I should have inferior result regarding management of vascular injury, contamination, a sterile ambience milieu with an unsterile one. Replace a simple reconstruction that we need only put the periost level if we resected this tumor from above, compared to a complex and less efficient reconstruction procedure with all these mucosal flap and other stuff, and compromise the integrity and the hygiene of the nasal infection. That's why I feel meningioma is still to take them from above, whether it's an olfactory, whether it's a planum. We have a simple procedure that you can take it safely. Why I should go the hard way? This is an example of a case of craniopharyngioma. It was purely cystic, as you see on the images. There is even some leveling here, the solid part and the anterior part. And here we were tempted to take it because it's cystic, and then we thought, let's give it the benefit of doubt. This is the way I feel the indication of endoscopy from below is very logic, because you don't look to the lesion coaxial like you're doing through the lamina terminalis. Here you look directly in line of vision. And except in cases of heavily calcified or multi-compartment craniopharyngioma, I prefer to go from above. And this is a case done from below and a simple approach, endoscopic assisted, not extended. And you see post-resection, very nice result. This is a case, another case of craniopharyngioma, and is a patient who is 60, operated in France for transfemoral surgery, release of a cyst fluid, and complemented with gamma knife radiation, steroid radiation. 3 years later, he presented to in his country, in Saudi Arabia, to our institution with progressive visual loss. And we decided to take him for surgery as the tumor is heavily calcified and the recurrence after gamma knife radiation. These are the two indications I feel this is a must to go from above. And this is a right peroneal approach. The optic nerve is stretched. You see the calcification underneath this optic nerve. This is from the opticocarotid area. The roofing of the orbit, they give you manipulation potential and more space in that triangle. And then I want to show this picture. You see the vessel. This is a superior cerebellar artery, and the calcification was heavily attached to this one, that we have even difficulty to dissect it from above. You can imagine you have a bleeding from this one while doing transfemoral surgery, and you might subject patient to a high morbidity incident. This is the endoscopic picture. It shows the optic nerve, and this is some calcification along the stalk that we could retrieve it nicely from above. And this is pre and post-op, even the calcification could be removed completely. Going to the posterior fossa, the simple approach replaces the complex approach, and this is the position I'd like to do. I know many, they like to have the sitting or semi-sitting position, but I adapted the sitting position in a lateral position. So I get all the advantage by having the upper part of the body elevated if I need it, or down, and rotated in both directions. You need to have a table that can be fractured in the middle. And this is the highlight of the incision. This is the exposure. You see even the fourth nerve, you can see high up in the ambient system. And that approach published earlier by Professor Majid Samir, almost about 10 or 12 years ago. The suprameatal approach is a fantastic approach. It gives you access to the peak of the petrous. And if you complement your approach with an endoscope, 30 degrees, you will reach even to the posterior cavernous from here and the Mickel scale. And I'll give you an example. In this case, we were tempted to do a combined approach because it goes high above the tentorium. but it's still under the tentorium. And look to the sigmoid and the lateral sinus. They are very prominent. They won't give you space, whatever you drill, unless you do a lot of drilling, you will damage the cochlea and vestibular to come pre-sigmoid and the treatment triangle. In this case, I decided to go from behind, take whatever I can take safely, and then we'll judge the residual if it's need additional surgical treatment or radiosurgery. This case was a perfect situation where we used the endoscopic assisted and we could remove this tumor nicely high up. I'll give you a short video here. How we take these meningioma. You see, I treat them like any convexity meningioma. And this is the tentorium. We devascularize. This is the first part of the D, the 5D. An important peeling the arachnoid. Peeling, not pulling. And this is very important description learned from Professor Majid Sami. And you see, you can put the scope, see before you resect even the third nerve and the ambient cistern here. And then you can do the, after devascularization, debulking. And then we'll move. I want to go further here fast. Devascularization, I'm using the cursor to decompress. I'm very safe there. No cranial nerve in this area and before inferior to the tentorium. This is the preferred approach for my colleague and friend, Professor Vladimir Benish, infrasupra. I'm doing it lateral infrasupra. And then after the decompression of the tumor, I start lifting the residual tumor, keep some thick capsule, and peel the arachnoid, which is, as I said, your natural patty. Irrigation, no coagulation. Don't weld this arachnoid to the tumor capsule, because then you will damage all the venous system around it and cause trouble to the patient. And the tumor will be taken out. It's very nice. And I put the endoscope again. I will see it here. Some nice views of the endoscope. See, this is the 7/8 complex. This is the 6th nerve going to the canal, and you see branches of the ICA down. Move to the next one. Epidermoid is another indication for the endoscopic assisted epidermoid is a tumor that can extend to all system, does not respect anything. They go around the vessels, but it's very nice to remove, like what they call a chopsticks technique. And you see, putting the endoscope, it gives you a nice view of the vertebral artery, the caudal cranial nerve, 7 and 8 complex, in a very nice situation. There's another video here, perhaps. I like to show it because it shows simultaneously the view. You see it under the microscope here and under the endoscope. The endoscopic picture shows you unbelievable panoramic view, and these are the tumor. You can just you need a nice dissector and irrigation and suction. That's what you need. I don't use the CUSA on these cases because it might be strong unless you use it on a low power situation. So you go on the different areas here, and you see at the end of the procedure, all cranial nerve are intact and safe. Oh, and you see no retraction is on the cerebellum, applying this position I have mentioned. So this is the views under the endoscopic procedure. You see the caudal cranial nerve, 7/8 complex and trigeminal nerve, and this is pre and post, very nice resection. Another indication is the pineal region tumor, the infra-supra approach. Now we move to unilateral approach, but I show you some picture here that we took while we're using the extended, the hybrid endoscopy with the microsurgical, microscopic resection of this tumor. And you see how nice the view. You are seeing all the third and lateral ventricle from the posterior approach. And you see the massa intermedia, the furnace, aqueduct, and this is a residual tumor that we could retrieve. And this is pre and post resection. Endoscopy has contributed tremendously. These are the two approaches. I said the pre-sigmoid approach. This is the Truman triangle that needs a lot of drilling. This is 3 procedure in one. Simple mastoidectomy, as we are doing here, the flap. We'll do a temporal craniotomy with a suboccipital craniotomy, and then we drill partially the apex of the petrous, and then I get the superior petrosal sinus. Once you are there, it gives you a wide exposure from cranial nerve 2 to 11. This is a fantastic when you come to tentorium along the tentorial edge. But by the time you reach the actual work on the tumor, you have 12 or 10 hours of drilling and exposure. The same applies for the far lateral. Nowadays, I rarely do the transposition of the vertebral artery. Most of these cases, at the level of craniocervical junction, that tumor give you a space. Releasing of the ligamentum denticulata and decompressing of the tumor will give you a space that you can work in very safely and applying the microsurgical technique. And Professor Yazavji, years ago, has taken many tumors and vascular lesions and clipped big aneurysm from a simple medial suboccipital approach. And that's what we do. But again, it has some indication if you are doing a complex skull-based tumor that can be extra intracranial. And this is, the indication has changed. This is a clivus chordoma. You see what's happened to the midbrain and the pons, severely compressed, but the tumor is purely midline. This is the brainstem, this is the basal artery. The basal artery is displaced posteriorly, is within the containment of the 2 Dorsal canal. So I elected to go from the front, decompress the tumor, and then we'll decide about the next, whether we need complex approach or we just refer the patient to proton beam radiation. And this case was, the view was fantastic, transclival approach, endoscopically assisted. And this is the post-resection patient. In 3 days could go home, and we refer him to proton beam, and he has been for 6 years free of any recurrence. And you see the fantastic re-expansion of the midbrain and the pons to and basal artery back in position. This is another case, but it's a meningioma. To tell you the truth, we misjudged it. We thought this is a chordoma, similar to the previous case, and I decided to go after it, like what we did in the case. Is a purely midline. There is a good arachnoid layer around the tumor. This is very important. Vessels are on the side, as it showed here. The basal artery completely displaced to the contralateral side. So we went in, it was a soft tumor, it was a meningioma that would be removed. This is the pre, and this is post. You see the midbrain, how it's compressed, there are the pons, and you see the expansion of the pons back in position. So the prerequisite for optimal approach selection should be safe and short and provide excellent depth and panoramic view, as I said, with the help of the endoscopy. Decision-making will be dictated by the location, size, direction of growth, and the pathology and the vascular anatomy. Factor influence approach selection. There is an inherent bias in neurosurgical training. You are trained by somebody. 2 minutes, I will be finished, the last 2 slides. There is an inherent bias in neurosurgical training. You got trained by somebody who will do only complex skull-based approaches. You will grown up with this and you will keep attached to them. But eventually you have to make your own judgment to modify as it's needed in your hand. There is a surgeon preferring this rigidity versus flexibility. There is a cost and logistic related and industrial driven practice in general. So in summary, simplicity trumps complexity, as I tried to prove. It's the zenith of a long, arduous journey, not the starting point, and flexibility trumps rigidity. I thank you very much for your attendance.
Thank you very much, Dr. Anad, for this very nice and very interesting lecture about your experience about this kind of surgery. And I'll open the floor for any questions for Dr. Anad, please.
Dr. Ahmad, thank you for this presentation. It is really astonishing how do you remove tumor, especially in front of brainstem. I have just one question. When we do surgery for epidermoids, we have the very high risk
very high rate of recurrence. What do you do to prevent this risk of recurrence? Do you remove the membrane or only the contents of the cyst?
No, for arachnoid, for the epidermoid, some areas of the capsule, they are very easy to dissect, and I'll dissect them. But area where it's very adherent to the cranial nerves and vascular structure, I will leave them alone. They have been proven many years ago that the recurrence rate 20 to 30%, but after 7 or 10 years, by cases that time the publication was even before the time of endoscopy. Now, if you chase this tumor in all the cistern and do resect good component of the capsule, you will be okay, because you don't want to replace a patient who sometimes comes only with headache with having a cranial nerve deficits. The ego should not overcome the quality of life of a patient. That's very important in the decision making.
Thank you, Dr. Ahmad. I have two questions. Please, when you transsphenoidal endoscopic, you have any incidence of complication?
Sorry, can you repeat the question? I'm not seeing the picture. Can they check me out so I can see you guys and I can hear you better?
Thank you, Dr. Ahmad. Transsphenoidal endoscopic abroad. Are there any incidence of complication like pneumotension, pneumocephaly, chest leak, diabetes?
Yeah. You see, I specify in my hand, I did the pure endoscopy and I'm doing more the endoscopic assisted because it's, for me, I get the benefit of the endoscope, but less invasive. What's happened for me, most of the people, they have done pure endoscopy. They were collaborating with an ENT. They learned the approach to ENT going through the ostium. And for this reason, they have to mobilize the turbinate in many cases, prepare a flap ahead of time. And this is why they want the ENT colleague. No problem with this. But the approach that I'm using is the direct approach with the small mucosal flap. The amount of leak is, for me, in my hand, is very minimal. Of course, we cannot avoid it in the giant tumors, but the double layer technique, putting the inlay and outlay, is very important. The inlay is very important. I do use the Duragen with some tissue, and I put the fat, which is the best tissue to support your inlay. And we leave in lumbar drain for 2 to 3 days to reduce the pressure of the CSF. Once this 3 days, if there is no leak, we'll take we challenge the lumbar drain and then we remove it. And in most of the cases, we could handle it this way. The complication published in the pure endoscopic surgery were tremendous because they go the extra limb more. Now they are trying to get the cavernous sinus surgery through endoscopic surgery. This is, of course, more of a complex approach, but I would see the indication for functional neurosurgery, not for the supracellular tumors and things like that. So the indication becoming more for the endoscopic, and that's why complication rate will be higher.
Dr. Professor Ahmad, very nice lecture. I want to ask you something which is of great importance to all colleagues. The vascular encasement. Now, normally we have an arachnoid and then we can peel off these meningiomas and we don't get into trouble. But there are rare cases where apparently, especially the major vessels, the carotid is really, the meningiomas start to kind of infiltrate the wall. That's what people say anyway. What is your advice? What are your observations?
If the adventitia of the vessel involved, leave it alone. I don't want to damage the most important supply for the patient brain by trying to challenge myself, taking additional 1 centimeter more of these tumors. You see, this is very important. Now, the other things, the use of Doppler during this procedure is very essential. So people, sometimes they go in, no Doppler, no mechanism to identify where the vessel in the middle of this lesion. I think Doppler is a very important and cheap tool to use. And now, of course, they have the fluorescein guided, they can visualize where the vessel is. We don't have this approved in Riyadh, but these are the mechanism, but we don't go and challenge the advantage of the vessels. And remember, it's not only the big vessel. Perforators are more important, like the Hübner vessel.
Yes.
Yeah, this is more important. The vascularity, hypophyseal trunk to the optic nerve, they are more important. So we should not neglect these perforators.
Yes, and especially in the area of the carotid bifurcation. But still, I want to ask you, you know, Professor Sami, and quite rightfully so, and not only him and others also always emphasized.
Sorry? No, I don't hear you.
Will eventually, if you debulk enough, the tumor will fall away. So my question really is, how do people tell whether the tumor is really infiltrating the adventitia of a vessel?
If you take the arachnoid and you are able to peel it, then it's no infiltration.
Yeah.
If the arachnoid is not peeling from the carotid and a very severe adhesion, this is an infiltration.
Okay, I agree. Okay, I just wanted this to be discussed because it's very important, because nowadays we are being reminded by Dr. Al-Mefti again that we should do radical removal. However, there is a limit to, you know, too much of good is a bad thing, maybe.
We respect Dr. Al-Mufti's statement. We always learn from him, and he has been an avant-garde skull-based surgeon. We'd like to, but we have to respect other international speakers like the one you mentioned, Professor Sami, Professor Yasajid. They were avant-garde, and we have, this is your own judgment, how you feel for your patients.
Yes. Thank you very much, Professor Imad.
Thank you.
Thank you very much, Dr. Imad. Very nice.
With pleasure. My regards.
Your participation with us. Next, we will move to the next speaker.
Thank you, Professor Ahmad. Thank you very much for joining us. And it was great presentation and great lecture.
Thank you.
Honor to have you in our conference.
Yeah.
Mr. Ahmad, you can hear me?
Yes, I'm here. I'm just checking myself out. So I found the button. Okay, well, it's wonderful to be with you and to see all the colleagues. I'm seeing Dr. Patiban and hi, how are you? And other colleagues. Great to be with you.
Thank you.
I'm fine. Are you able to see my slide?
Yes. Now we have Dr. Jyoti Parthiban from India. We will present.
You're able to see my slide?
We can see you, doctor, but we don't see your screen. Please.
You're able to see. You're able to see my screen?
No, you don't share. Share your screen, please.
Okay. 1 second. Are you able to see that?
Not yet, Professor. Not yet. Yes.
Now?
Now it's good. Now it's good. Now
It's okay.
Okay.
Yeah, thank you, friends. It's a very pleasant day for me to be with all of you, with the MNE neurosurgical team. It's my pleasure to talk on my pet subject of cervical myelopathy and the management approaches. I'm sorry. Yeah, so myelopathy, we see quite often, we see different kind of patients coming to us with different clinical situation. Most of the patients come to see doctors, many doctors at a time.
And finally, you are there to decide on what else you can do for these patients. Basically, myelopathy starts with a compression of the spinal cord, mechanical compression, and then the vascular impediments, so many and so forth. Then the patients do have quite a bit of clinical symptoms, and then the signs. They're all not very systematic, they are very chaotic. Some patients do have compression but don't have any sign or a symptom, but some patients have got very minimal compression, but they do have a sign and symptom. So this is basically, that is the one way that makes the decisions very tough for the neurosurgeons. As is seen in these pictures, that you can see the compression is compressed at 2 levels, but one can have an ischemic change at a higher level or a lower level, and that can cause myelopathy. At the same time, cervical spine has its own movement of flexion and extension. Some compressions are more during flexion, some compressions are more during extension. So this biomechanics has to be understood by the surgeons before they decide on. But then, however, we all put ourselves in assessing the patients with the Japanese Orthopedic Association score, which is a very basic and simple one, and that we can easily apply on the patients and to know to which conditions they are in. And sometimes, this is a basic Japanese JOA score. And in the Indian context, and there was some more thing was added to buttoning the shirt, and also the tearing the food, like roti, chapatis, and sure. It's depending on each country, it differs. But then basically we have a few scores, but MJOA is one of the best one, which we are all over the world. Now with this, with the classification is made, like when there is a mild myelopathy, that is about 15 to 17, and the moderate is between 12 and 14, and severe is less than 11. So we all know about, very easily we can understand that, if you have a moderate and a very severe one, they are more significant when compared to the mild type. So the practice methods came and how to go about with these cases, with Michael Felling's team and telling about it, that mild, the guidelines suggest that offering for mild one, offering a surgical intervention or a supervised trial of a structure rehabilitation. If initial non-operative management is pursued, the operative intervention is recommended for patients with neurological deterioration, and operative intervention is suggested if the patient fails to improve. But as far as the moderate and severe are concerned, that you need to suggest surgery. Though the quality of evidence is very moderate and the strength of recommend is very high for the moderate and the severe. But for the mild one is the problem. So there were many guidelines that AVO-Spine and North American guidelines were given in 2017. And subsequently in 2018, the WFNS Spine Committee had a consensus meet in India. And with that, the committee also came with a consensus on this evaluation of how to go about these patients. And then the consensus results were published in 2019 in Neurospine Journal. And this is the difference between the AVO-Spine North American CRS guidance and also the press. It's very minimal. Not much has been changed, but except that there is a little bit more aggressive in the approach by the WFNS Spine Committee group. For example, here, if you see a moderate to severe CSM, you have a surgical intervention is definitely is recommended, no doubt in that. But if you have a mild one, mild CSM, then you suggest offering surgical intervention or rehabilitation of the patient with mild CSM. If at the beginning, if a non-operative management was followed, we recommend operative intervention when a rapid progression of the symptom appear. So this means that the patient has to be in contact with the same doctor. A non-operative conservative management may be considered for slowly progressive disease. So if a patient is in continuous touch with the doctor, and then he can easily find out where the patient is progressing fast or slow in mild cases, which is very important for surgical decision making. At the same time, another presentation in the mild is that you do find that non-myelopathic patients do come with evidence of cervical cord compression, but there are no signs and symptoms of radiculopathy. This usually you see when you see a degenerated lumbar spine. So usually in these cases that there is no surgery is offered, but these patients should be counseled well for the potential risk of worsening and educate them about the signs and symptoms, about the progression, and follow very regularly. We usually take an informed consent from these patients that this has been discussed with the patient, because usually patient can go in some places for litigations of that the surgeon has not explained to this or not. So it is be very careful with this. At the same time, some non-myelopathic patients with the cord compression have very minimal clinical evidence of radiculopathy with or without electrophysiological confirmation. When you have a radiculopathy, they are more potential patients to get deteriorated. So you must give them completely, you must warn them that this is what's going to happen. Though we give a structured rehabilitation program, these patients must be given clear indications that they have to undergo surgery in case of worsening. In the event of developing a myelopathic signs, they are advised to go for the surgery at the earliest. So this is very important. This is what the WFN Spine Committee came into a conclusion finally, and this is being presented and which we follow it all over the world from the WFN Spine Committee group is concerned. Now coming to the surgical strategies of the management of cervical myelopathy, I have to make it very simple in this because we have only two approaches. One is anterior approach and posterior approach. And this K line is being used as a traditional one. The K line is a midpoint of the horizontal line of C2 base, and also about the C7 spinal diameter. You know, if you put the line and you have the compression which is coming from posterior compression that crosses the line, it is K line negative. That means there is a mild kyphosis there. There can be a kyphosis or the compression is crosses the midline. So this is K line negative. If you don't have, if the line is not touching any of the pathological structures, that is K line positive. Basically, it is designed for OPLL, but in myelopathy, most common is the degenerative cervical spondylosis, and then with OPLL. So K line is very important thing. With this, we can always say the anterior procedures are ACDF and then the corpectomies, with or without instrumentation. But when to do that, you know, when we pick up the ACDF, that is a single level pathology, the disc level compression, and there are osteophyte at the disc level, a single level, and if you have a single level at the multiple disc, then one can go ahead with ACDF, that is the disc level kyphosis. You can see the cases here. Here is a patient with a 4-5 compression, and this is a 4-5 compression, is single level, and one can go for a straightforward ACDF. It's enough. But a similar example here at C3 and C4 and single level, you can go in for a standalone ACDF with a cage. That's good enough for this patient. But there are patients who can have 2-level compressions who started going for a compression over a period of time. As you see in this case, here you can see that in 2008, you have this compression here. This is a doctor who had a progressive neurological symptoms and then signs, and there was a gynecologist who could not even operate later on. And had no choice, and then she has to go through surgical procedure at 2 levels, like similar. Now in this, if you look at the K line will be negative here because you have a segmental kyphosis which is forming at 4, 5, 5, 6 in 2 levels. So this is an ideal case for doing an anterior approach, like at 2 level. This will solve this patient's problem. But we do have, sometimes rarely you can see cases with myelopathy which come with the skip level disc prolapses. Like in this case, it does not matter where it present here, and you can see very obviously about C3 or C4, 5, and then later on at the lower level with the clipal field in between. But this is operated at 2 level with two level anterior cervical discectomy and fusion. And here the clipper field is not much changed because we just went through only for what it is required in this patient. This patient is doing very well. Now, in some patients, you have a C5, C6 collapse, and there will be a progressive kyphosis. And if you see here, you can see that it is worsening and there is a mild instability is forming. And this type of cases, it is preferably to do fusion, not only interbody fusion because of instability, you also add an instrument over there, and those compressions, I don't have an MRI here, those compressions below and above, and then you can add the Graft's ACTF as well. So this is standalone, and you can do only fixation and where there is instability and where there is not instability, that you do not need an implant to be extended much. Now, this is another case that you have, it looks like that you have a more compression at this level, but then there is also at this level and also this level, and you find that there is a change in the spinal cord signals there. These are the osteophytes here, the disc and the osteophyte is going there. So it looks like it is having at about 3 levels. In 3 levels, in this here also, we can do 3-level standalone cage fusion. And these 3-level cages can hold the lordosis, early lordosis, but we do have see that there is a loss of lordosis after some time, but does not matter. It is not clinically significant, though radiologically interesting. Now, if you want something more, if you don't want that to happen, then you can always add anterior plating to maintain the kyphosis and prevent the settlement of grafts. So grafts always settle, that if you put only an iliac crest graft, you have the tendency for the graft to settle down. But if you put the implants, it does not settle down. So the implants does help in preventing the settlement. At the same time, it also maintains the kyphosis, but at the cost of higher instrumentation in these cases. Now, going to the vertebral body level compressions, then we need to go in for a corpectomy. But if you have a multiple level disc degeneration with reduced body height and associated subluxations with a kyphotic cervical spine, these type of cases, we can always go in for a corpectomy, and then you can put cages of a kind. This is a standalone cage with a distraction cage, and you can see the neutral extension and flexion views, and there's no problem in this type of cases. Here is another example where you can see as a patient became quadriplegic after an injury, but the history of myelopathy. This is a very classical case of patient who had history of myelopathy with a trivial injury, gets into a quadriplegic and quadriplegic fall, small fall that triggers C4, C5 subluxation. And in this case, we went ahead with doing the corpectomy at 2 levels and then fixed the spine from anterior. So this will solve very nicely. It's a very classical case that where you can see your K-line, your kyphosis and everything, but the complete compression is from the front. So you may have to go do this surgery from anterior with an instrumentation, particularly with implant, anterior cervical plate and screw systems. Now this is another case with multi-segmental level where a kyphosis is going on. Then we go ahead with doing anterior plating, and also the levels that needs a single level, we do isolated interbody cage systems. Now, so an anterior approach is very simple, that you do anterior single level or 2 level up to 3 levels. More than that, it's always very difficult in OPLL, and the K line must be negative to do these anterior surgeries. For the posterior procedures, the posterior procedures are, we have very straightforward laminectomy, laminoplasty, plus or minus instrumentation. Posteriorly for OPLL, it is always considered that if you have a compression for more than 3 level or more, and if it is complex and bizarre OPLL or compression of different types, where you may find a difficulty doing the drilling of the anterior complex, then you can go in for a posterior approach. the K line must be positive. That means the K line positive means that you have a good kyphosis. Yeah, 60% of the canal index. If it is, yeah.
5 minutes, please.
Hello?
5 minutes. Due to time.
Oh, yeah.
5 more minutes.
Oh, okay. Okay, so posterior approaches can be done in this way. As I said, that I'm going through these cases. This is simple laminectomy, and you can see here, you can do a suspension, whichever technique you like, you can do, choose the type of technique you like. The suspension laminoplasties were done, and then you can do the split type of laminoplasties. You can also do a many laminoplasties of different types. This is for posterior approach. Instrumentations you can use if you suspect that this patient is going to have a loss of lordosis and kyphosis. So you can add the lateral mass instruments to this. An important point to tell you about the lateral mass is to any level, you can do it for multi-level instruments if you feel that it is going to have a kyphosis. But here in this case, you can see here C2 is not included, but then in some cases, you may have to include C2 also because you need to preserve the patient's kyphosis. Thank you very much for your attention.
Thank you very much, Professor. It's great presentation and great lectures. I think there is many questions. Dr. Jamil Al-Absi, consultant neurosurgeon, will ask you some questions.
Yeah.
Thank you, Professor. Please, you can tell us your early and long-term results, please.
I'm not able to hear you.
Please, you can tell us your early and long-term results.
I'm not able to hear you well.
Post-operative result here in the early stage and in the long term follow-up. It is asking about the outcome of these cases. In the early and in the long term, okay?
You're talking about the outcome of the standalone anterior cervicals? I'm not able to hear you well.
You want to ask about the outcome
The voice is not
of your surgical approaches in the short time and long time.
See, I'm not able to hear you, but I can tell you one thing. The outcome of these patients, whatever we have done with the anterior standalone approaches, are very good. You believe me that we go through up to 3-level anterior approach with ACDF, a single standalone ACDF. They do have some loss of lordosis over a period of time, but they are not clinically significant. Okay. I'm not able to audible from your side.
What about,
No.
About neuropathic case result?
Sir, I'm not able to hear you well.
He's asking about the cases with myelopathy.
Huh?
He's asking about the outcome of cases with myelopathy.
Okay. Right. I come to the point. See, my personal experience is that if the surgery is done very early, the results are good. But if the surgery is delayed, for example, the patient comes with a wasting of the hands and they don't do well. So the important thing is that the decision making at the earliest point. The whole ideal situation here is that we do not know at what time the patient comes to us. But ideally, I feel that if you do the surgeries, whatever surgery you are planning for, we do it early in the clinical picture, that is in the mild group. When it comes in the mild group and shift towards the moderate group, I think the results are good. But in the severe group, the results are not that good, though there is an improvement in spasticity, and it is very difficult for the patient as far as the motor functions are concerned.
Thank you too much. I have two questions.
Yeah.
In Yemen, the majority of cases which we faced are spondylotic myelopathy. They have disc osteophyte complexes and canalicular posterior decompression. So what we do is only anterior without trying to remove the osteophytes, and later on we can do posteriorly. In your cases, you do always resection of the osteophyte, or you leave the osteophytes? Because
Yeah, I'll come to that. See, what you're trying to know. In my policy, that you have to remove the osteophytes. If it is seen compressing, we have to remove. We have to drill it out. We have to drill it out, the osteophytes, meticulously. That's the only point herein comes. If we do both ACTF, the corpectomy, when you do corpectomy, it is easy to do the osteophytectomy. When you do a single level, it is difficult. So that is why many surgeons, they do a corpectomy and then do an osteophytectomy as well. I strongly recommend that we should try to remove the maximum the osteophytes. The one important thing is that the central osteophyte. See, for example, there is always a difference of opinion that how much to decompress, right? Now, we all believe that we have this anterior spinal artery which goes to the ventral and the midline, and that part actually you must at least minimum of 1.5 to 2 centimeters. The osteophyte in the central must be drilled out. So that is very important. The second thing is that whatever I've seen in many patients, like what we see, the patient will have a kyphosis in a neutral. When you put the patient in position on extension, you do find there is a reduction. There is a reduction naturally. What makes the patient for kyphotic is because of the pain and also the muscle contractions. When we put the patient on table, you can see very well, you see the kyphosis getting lost. They are not fixed kyphosis, not many. Few are fixed kyphosis. The many kyphosis disappear. So when you do it, I would prefer that you also do the osteophytes, because you give one step elevation of decompression of the spinal cord.
Okay. So the other question, please.
Thank you, Doctor. We have one question from Dr. has one question.
Yeah.
Yes, Dr. Muhammad will ask first.
I have another question, please. In cases of ossified posterior ligament with myelopathy, what is your approach? Cases of ossified posterior longitudinal ligament with myelopathy, what is your approach in such cases?
I'm not able to hear you. That voice, I'm not able to hear the sound.
Ossified posterior longitudinal ligament with
C5? C5?
Ossified, calcified.
Calcified.
Posterior longitudinal ligament, OPLL.
Okay, OPLL, right. Okay, right. See, now I have two points in this. As far as the OPLL is concerned, you have to drill the OPLL as much as close to the dura is concerned, because in some places you don't find the dura. In some places you don't find the dura. So in those cases, I'm talking about in OPLL, in those cases you can leave a thin layer of the OPLL, float it out. You don't need to excise that, because if you try to excise it, in fact, that you may not find the dura, you find only the spinal cord, anterior spinal cord there. So in those cases, that in OPLL, you thin out the OPLL maximum, and then release those OPLL by segments. You can see the pulsation. The OPLL must be thinned out and then release it from the laterally, and one can see the pulsation. Then we can stop the surgery. You don't need to remove it completely. OPLL.
Thank you. Dr. Fatah, you still have any question or the same question? Thank you, Dr. Bartiban. There's a great lecture, great presentation. We are honored.
Thank you.
Dr. Ahmed, Dr. Ahmed Susu, have a question.
Yeah.
Thank you, my prof, for your nice presentation. In my small experience, I have two complications and I couldn't find the explanation. One of my patients get plexopathy after surgery. Without traction, we are not doing traction. And one of them get plexopathy. Done MRI, and there is no organic compression to any road. The other case, the patient had severe myelopathic changes, and we make very good decompression. The MRI shows good decompression and no more myelopathic changes, but the patient gets worse in his power and in his spasticity. Could you, are you found some complication like this?
Yeah, see, it's very unfortunate, but we do not know what the reason for the worsening. I personally feel that, the first, the reason for the worsening may be something on our technical aspect. Somewhere, that's what my personal feeling is. Though the history, the old teaching us that, sudden decompression can cause intramedullary hemorrhages and edema. So we are very not sure about it. I'm not sure that now how many of us are using intraoperative neuromonitoring in these cases. Now we start doing with intraoperative neuromonitoring. Intraoperative neuromonitoring, and we do the SSCP continuously recorded. SSCP continuously recorded, both whether it is an anterior surgery or posterior surgery. And cortical MEP also is there for trigger. So what I suggest is, personally I suggest is, because to avoid this type of surprises, I think we must include intraoperative neuromonitoring in cervical myelopathy patients, particularly when the cord compression is very severe.
Thank you.
Thank you for the lecture. I have one question. We have some some percentage of patients after fixations, discectomy, 1 liver or 2 livers. After some time, the screw is loose. I mean, it's go from his side. Even with we fix it well and we do lock after fixation. Do you have any advice to avoid this? Thank you. You understand?
Dr. Bartaban, are you with us?
Hello.
Due to lack of time, we will move to the next speaker. Now we'll have Professor Vinod Felix from India, an ENT consultant, and he will give a presentation about vitreous endoscopic approaches for vitreous apex. Dr. Vinod, you can share your screen and you can start. Doctor, you can hear me?
Yes, yes, respected organizing team, dear senior members, faculty, dear colleagues, a very good afternoon to all of you. Can you see my screen?
Yes, we can see it.
So I'm going to talk to you about the transnasal and transaortic approaches to the vitreous temporal bone. So I belong to this southernmost part of India, a place called Kerala. It's a very beautiful place with a lot of backwaters and beaches. And this is my hospital. So coming to the basic anatomy, like it has a base, an apex, 3 surfaces, 3 angles, and it houses the vitreous ICA, facial nerve, vestibulocochlear nerve, inner ear, etc. All these things the neurosurgeons know better than me. So I'm not going to touch upon the basic anatomy here. And the approaches to the vitreous bone, the anterolateral corridor, the conventional petrosectomy, you're all masters and you know that very well. So the basic idea of this talk is to orient you about the alternate approach, because there are many ways to skin a cat. And at times you need to know the alternate approach also. The approach depends upon the pathology, anatomic location, and expertise. You all know that. The pathology and location cannot be changed by human minds, but the expertise can be changed. And you shouldn't be handicapped at the moment because you're not expert in handling a pathology through the alternate corridor. And the main idea of this talk is to orient you about the alternate endonasal corridor and transaortic approach to the Peters bone, so that at least some of you who are not so good in these approaches, after my talk, will be interested and will learn this approach in the future. So there are different sort of pathologies in the Peters bone. Let us start with this example, the cholesterol granuloma, which is a very common example of a Peters apex pathology. And this is actually a classical pathology where you would like to do an alternate approach, the endonasal or the transaortic approach. So based on the location of the Peters the cholesterol granuloma to the horizontal Peters carotid artery, this is the parapharyngeal carotid artery. In case the cholesterol granuloma is lying close to the sphenoid sinus or in the medial part of the Peters apex, you could easily approach the lesion through the endonasal corridor. Whereas if the lesion is lying on the lateral aspect of the ICA or close to the internal aortic canal, you would do this. You would approach this through the intracochlear approach. And to determine the best approach, there is something called the Pelusi's angle. This may sound a bit complicated, but it's actually a very easy thing once you understand the concept. So you need to draw two lines. The lesion is on the right, this side, on the left side. So the endoscope would land on the contralateral nasal cavity. So the first line is called the pyriform aperture laceral carotid line. So you draw a line from the pyriform aperture here to the medial aspect of the carotid here. So this is the pyriform aperture laceral carotid line. And next is the line from the pyriform aperture to the medial aspect of the lesion. In case this second line, the lesion line lies medial to the first line, you could easily approach the lesion through the endonasal corridor. And if the second line, the line drawn from the pyriform aperture to the medial aspect of lesion, lies lateral to the first line, you would of course have to drill the entire carotid, move the carotid laterally and then tackle the lesion. Or you would have to go approach the lesion through the intracochlear approach. This is a schematic diagram showing the intracochlear approach. This actually is a sagittal image. This is the tympanic membrane and the middle ear. The medial aspect of middle ear houses the cochlea. So if you approach into the middle ear through the tympanic cavity and drill below the cochlea in the window between the carotid artery and the jugular bulb, you would reach the Peters apex. So there is no external incision, just go through the ear canal with the endoscope. You are at the Peters apex and you can drain the cholesterol granuloma, provided the Pelusi line is negative and the granuloma is lying close to the internal aortic canal. This is the same image. It's actually the middle ear. Superior is above is superior, below is inferior. You can see the internal carotid artery and jugular bulb. And what is marked as PR is the promontory which is formed with the basal ten of cochlea. So if you drill below the cochlea between the carotid artery and jugular bulb, you are in the Peters apex. So with this brief introduction, let us start seeing the endonasal approach and transaortic approach in further detail. So coming to the endonasal approach, you are somewhere outside the nasal cavity here, and the Peters apex is somewhere here. So you need to approach through the remove the medial wall of maxillary sinus, the posterior wall of maxillary sinus, drill the pterygoid base here, and only then you can approach the Peters apex here. So that's a maxillary bone. You have to drill the maxillary bone, get into the maxillary sinus. And the next, the image on the downside right shows the interior of the maxillary sinus. And the next image was the posterior of maxillary sinus removed. And then you have the pterygopalatine fossa. And you are seeing the maxillary nerve and the sphenopalatine artery, the Vidian nerve, etc. in the pterygopalatine fossa there. Of course, you have the fat there. The fat has been removed here to show the structures better. And this is the close-up view of the right side. And this, you are seeing the maxillary nerve above running to the foramen rotundum. And below the foramen, the inferior aspect here is the Vidian canal. So the Vidian nerve is a very important landmark in the endonasal approach, because once you drill around the Vidian nerve will take you to the foramen lacerum. So to approach the petrous apex, you need to identify the foramen lacerum, because the petrous apex is right behind the laceral carotid. This again is an anatomical picture showing that the Vidian nerve taking to the foramen lacerum. And once you identify the foramen lacerum, and if the Palsy angle is positive, you can approach the lesion very easily. In case you have the negative Palsy angle, you have to drill on either sides of the laceral carotid and lateralize the carotid so that the petrous apex is right in front of you. Let us see a case scenario. Here we have a lesion, the right petrous bone. And we are going to approach it to the endonasal corridor and get the maximum debulking and get the biopsy for this lesion. So that's the right side. We have opened the maxillary sinus, and you're seeing the pterygoid base. We have removed the posterior of maxillary sinus. And this here is a Vidian nerve. And what I'm touching is right now is a foramen maxillary nerve taking the foramen rotundum. And I opened the sphenoid sinus wide, and I am drilling around the Vidian nerve to identify the foramen lacerum. And you are seeing the carotid artery just behind that. So that is a Doppler, and that's you are seeing the carotid artery being marked by Doppler there. That's a laceral carotid. The entire paraclaval and a part of the horizontal petrous carotid artery has been delineated. I am drilling the petroclival synchondrosis and the part of clivus there, so that I get into the petrous apex. So I have drilled on either sides of carotid artery. So you can see that the carotid artery can be lateralized now because the either sides has been drilled now. There is further drilling of the clivus. And that's my curved suction tip going into the petrous apex. So that is the petrous apex region. We already partially debulked the lesion there. So that is how you approach behind the carotid to the petrous apex. We are curating the lesion behind the carotid artery. And so there is no CSF leak here because it's completely extradural approach, and you don't need any flap here. There is just a free mucosal graft, which I laid to aid the healing process. So in case the Palsy angle is positive or somewhere between -4, etc., you can approach the lesion with this corridor. And this endonasal approach is good for lesions of petrous apex. But if you have a lesion in the petrous body or the lateral aspect of the petrous temporal bone, you would have to do it with an alternative corridor, or you have to opt for the newer endoscopic approach called the contralateral transmaxillary approach. In the contralateral transmaxillary approach, we come through the opposite side maxillary sinus, we make a small incision, the oral cavity, sublabial incision, get into the contralateral maxillary sinus, and then we approach the Peter's body. So that was about the endoscopic approach. Let us now see about the transaortic approach to the Peter's apex. So from this image, you can clearly see that between the red lines, the red lines show the temporal bone. Once you drill the temporal bone, you are on the, when you drill the temporal bone and you remove this labyrinth and cochlea, you are on the Peter's bone. So entire Peter's bone can be removed by drilling this temporal bone, and this forms the basis of the transcochlear approach. So this is the incision for that. You make a C-shaped incision just behind the ear. And sorry, I think I didn't insert the scans for this patient. So we had a clival, a chordoma which was extending to into the clivus and to the Peter's bone. The chordoma and the clivus was removed endoscopically, and now the lesion is, there is a residue in the Peter's bone. And we are going to remove the chordoma by doing a transcochlear approach. So that's a C-shaped incision. And the next thing to do is to do the blind sac closure of the ear canal. That's a blind sac closure of ear canal. Once you do that, then we proceed with the mastoidectomy. So superior is on the left side of the screen, superior is here. Inferior is shown by the, is below on the right side of the screen. So the patient is lying facing you, and in the upper part of the screen, you are seeing the tympanic membrane. That's a tympanic membrane. And this is the mastoid cavity. So a mastoidectomy has been done. The posterior canal wall has been removed. And we have entered into the middle space behind the tympanic membrane. The tympanic membrane is still intact there. And you're seeing this is a malleus, that's a malleus. This is the incus, and this is a stapes. And this is the facial nerve. This is the lateral semicircular canal. Now we have removed the tympanic membrane and all the ossicles. And this is the facial nerve. We have the delineated facial nerve a bit more. We have drilled around the facial nerve. And we have opened the labyrinth partially here. And this is the facial nerve. The labyrinth has been opened here. So we are drilling in the promontory. The promontory has been drilled here, and you are seeing the cochlear turns there. So those are the cochlear turns, and this bone here is called the modulus. The cochlear turns actually turn around the modulus. You are seeing the different parts of the cochlea, the scala tympani and the scala vestibuli here. So those are the cochlear turns. Once you drill all this cochlea, you are in the Peter's apex. So this is a schematic diagram from Professor Mario Sana's books. So this is the facial nerve, this is the internal artery meatus. The anterior here you have the internal carotid artery. The cochlear genu is here. And once you drill between the facial nerve and the carotid artery onto the cochlea, you are on the Peter's apex. So we have drilled the cochlea, the carotid arteries here anteriorly, and superiorly here we expose the middle fossa dura here. And you're seeing the carotid artery. This is actually the cochlear genu, facial nerve. That's the Peter's apex. This is a horizontal Peter's carotid artery. The foramen lacerum is here. So this is a schematic diagram, the facial nerve, the carotid artery. Once you drill the Peter's bone here, you'll reach the clivus. And there is an alternative approach called the transcochlear approach, where you move the entire facial nerve behind. You transpose the facial nerve posteriorly, you get a bigger corridor, and you can work through this corridor to even the contralateral Peter's bone. Such wide is the corridor when you do the transcochlear approach. And this is for a small, this is again the same image, the horizontal petrous carotid artery, the middle fossa dura, the facial nerve, cochlear genu, laceral genu. We are on the petrous apex. A small video clipping. We are removing the lesion from the petrous apex. We're working between the facial nerve here and the carotid artery. And from this image, from this picture, you can clearly understand that the main factor which is limiting your approach is the facial nerve. So once you transpose the facial nerve posteriorly, your corridor is much more bigger, but you will get a facial palsy for sure. There is the lesion being curated. I'll slightly fast forward this video. So this is the middle fossa dura, the cochlear genu of carotid artery. This is the entire horizontal petrous carotid artery. And this here is the facial nerve. And here you have the foramen lacerum here. And this is a post-op. The patient doesn't have much facial palsy because we are not transposed the facial nerve. The difference between the transaortic and transcochlear approach is in transaortic approach, you don't transpose facial nerve, whereas in transcochlear, you transpose the facial nerve posteriorly. So the basic idea of this lecture is to orient you about the alternative corridors to the petrous bone. So that at least some of you, I know there are many of you who are doing this good work here, but those of you who are not doing good work in these areas, probably you'll get interested and you would learn this approach in the future. So thank you once again for this wonderful opportunity. Thank you.
Thank you, Doctor, for this nice presentation. I have only one question. Do you do your operations in collaboration with a neurosurgeon or you do it alone?
Can you come again, sir? I didn't hear you properly.
In your operations?
Yeah.
You do it together with a neurosurgeon or alone?
No. All these surgeries we do with neurosurgeon, because once I cross the dura, it is not my area. It is actually the neurosurgeon's area. They are far well versed in the intradural anatomy, and definitely all these surgeries were done with neurosurgeons. And that's why in these two videos, there was an excellent neurosurgeon, Dr. Prakash was with me. He was the neurosurgeon for these two cases. And all my intradural surgeries are done with neurosurgeon.
And do you compare?
It's always a teamwork.
The results of neurosurgeons are the same or you are superior?
Beg your pardon, sir?
Do you compare your results with the neurosurgeon results or not?
No, all these cases are done along with neurosurgeons. So only if they decide that this is the best approach, we go ahead. In case they feel that the alternative approach is better, they go with the alternative approach. And I think the case selection for this alternative approach is very important, because if you feel that the conventional petrous apex, the open petrosectomy approach is better, you have to go with the conventional approach. So these are not for all cases. These approaches are only for selected lesions.
Thank you so much, Doctor, for your presentation. We hope to
Thank you,
see
sir. Thank you. Thank you.
Thank you so much.
Thank you, sir. It's a pleasant to be here. Thank you.
السيشن هذا خلص السيشن الثاني بعد نصير باقي السيشن معنا. Thank you so much.
Thank you.
Do we have now lunch time? 1 hour lunch time. After that, we have the next session. Thank you so much.
June. John, you hear me?
So the next session will start at 3 p.m. till 6 p.m. Now we have 1 hour lunch time. Thank you.